Hello. So, good morning, and we welcome all our dignitaries, chief guest, Professor Singh, Director, CME sir, and also Sarna, Professor of Management and Lucknow, XD, Jain sir from Professor Finance in India, and all our HODs, all the faculty members, our HOD, Dr. Alok Srivastava, and all our staff members. So we have gathered here just to have a informal, I can say it is not a formal, it is part of our activities. So to launch this digital studio, which are prepared in the existing seminar room of the department. I think all departments have a seminar room with the intention of letting the institution know that how the seminar room can be utilized using high-speed internet to connect learners across the country or across the states, whatever we want to do it. And making this utility of this technology for purpose-driven learning. It is a generalized technology, always neutral. So that we have done here. So the essential element that is high-speed internet, dedicated internet we have taken, and some of the audiovisual devices we have taken. And what it can achieve is in a collaborative way, it can connect to the intended learners or target learners. It has to be mutually agreeable situation, and so that it is successful in that. Our target in this situation is, because we are not started MCS, but we are a academic department. So we have to keep our mind and everything active. So we are connecting to our academic institutions across the country who are running MCS program, plus institutions who are preparing themselves to start MCS programs, and members of our association, Indian Association of Endocrine Surgeons, where this is going to act as a CME under the auspices of IAS. So that's the first thing that we have approached IAS, give us opportunity to connect members for disseminating the knowledge. The third thing that I want to tell you is we are using technologies which are affordable. These are all, not that expensive, and but you have to have kind of planning to do it, because in the correct sense, it's not a studio. Because studio means it has to be completely without windowless. It has to be treated with acoustics and all those things, and it cannot be so big. It should be a small thing. But studio concept has been introduced into the seminar room just to let the hospital authorities know that we can convert any seminar room to this kind of collaborative environment, because a lot of responsibility is going to come in the near future for institutions like ours. All of us must have seen the newspaper things that government wants the RML Institute also, in addition to other two institutes, to become the hub to disseminate knowledge for the medical colleges. It has a relevance because so many medical colleges have come up and we all know about it, the difficulties to get faculty. Maybe in the near future, our institute will play a big role in that. In that, our institution has a significance because we have a broad specialty also and we have a super specialty also. But the intention is to create that atmosphere, to motivate departments, to spare some time to help others, besides carrying out our own academic activities. So with that note, so I request our director to give an inaugural speech, a very brief occasion, and I request other dignitaries also to say a few words, and then after that we will take. It is a small function, as I told you, informal function. Sir,
sir, if you want to. निर्देशक महोदय, HOD एंडोक्राइन सर्जरी संस्थानों से आए हुए लोग और जुड़े हुए अन्य संस्थानों से विद्वान लोग, एंडोक्राइन सर्जरी डिपार्टमेंट के सर HOD प्रायः ई लर्निंग के मामले में काफी ज्यादा एक्टिव रहे हैं। हम लोग पहले से ही इस तरह से जानते हैं। टेलीमेडिसिन उन्होंने TIVAD शुरू की, उसी को देखते हुए हम लोगों का भी प्रयास है कि अपने विभिन्न विभागों में या इंस्टीट्यूशन में इस तरह के संस्था और चीजें स्थापित करें, जिसका उन्होंने आज एक छोटा सा उदाहरण यहाँ प्रस्तुत किया है। और हम भी सर से रिक्वेस्ट करेंगे कि सरकार चाह रही है कि स्ट्रोक केयर के मामले में पूरे प्रदेश में हब की तरह हम संस्थान काम करे और हब एंड स्पोक मॉडल में अन्य जगहों पर बने। तो मैं उम्मीद करता हूँ सर से हम हेल्प लेकर के अपने संस्थान में, डिपार्टमेंट में इस तरह की अन्य एक्टिविटी भी शुरू कर सकेंगे, जिससे पूरे प्रदेश को लाभ हो। मैं इसी के साथ सर को बधाई देता हूँ। धन्यवाद।
Good morning, everybody. It's indeed a pleasure to be amongst all of you here. And as we understand that telemedicine is one very big initiative that Government of India is focusing on, and that's how we can connect to multiple people at the last mile, and from there we can actually ensure that the doctor can reach them, provide them with diagnosis, and also post-surgery they can take care of them. And also the interesting part is that with AI and all these related things, where the data is one very important thing which can be gathered, and based on that analysis can be done, and then it can be used for treatment purpose. And also another interesting thing that's happening here, as Sir is talking about, is that dissemination of knowledge to all the other medical colleges across the country is also a very big initiative, because a lot of things happen in the surgery room which may not be known to other doctors and other medical hospitals. So it could be actually disseminated from there. And also he's talking about collaboration, because that is also a very interesting thing that we could also learn from each other, and that could be a great advantage. And that's where this sort of a studio is going to be very helpful, because I had seen Sir set up in SGPGI, where he had also set up inside the OT as well, from where he was beaming to other hospitals, medical colleges, etc. So it's a very good learning tool that we can all appreciate. And technology plus healthcare together is surely going to be a win-win situation for a huge country like India, which has so many sets of so many sets of people, so many sets of cultures, so much of issues and challenges. And with the doctor-patient ratio being low, this sort of initiatives, I'm sure, is going to help in driving the delivery of the public healthcare system immensely in the country. So a very big thank you for Sir inviting me, and hope this institute and this initiative does meet the requirements of the government, of the people of the country, and all of us can get the benefits out of it. Thank you, sir.
सबसे पहले तो डॉक्टर साहब को बहुत बहुत बधाई, एंड सर आपको भी। अभी जो रिसेंटली ऑनरेबल चीफ मिनिस्टर की जो आपने अगर पेपर पढ़ा हो, तो उसमें था कि सारे टर्शरी केयर हॉस्पिटल से हमारे जितने टेलीमेडिसिन स्पोक्स हैं और हब्स हैं उनको कनेक्ट करने की बात। तो स्पेशलिस्ट सर्जन्स, स्पेशलिस्ट डॉक्टर्स डेफिनेटली हमारे सिस्टम में, गवर्नमेंट सिस्टम में अभी उतने नहीं है जितनी ज़रूरत है। तो आई थिंक लोहिया इंस्टीट्यूट इसमें एक लीड ले सकता है, और KGMU है, लोहिया है, इसके अलावा और जितने भी टर्शरी केयर स्पेशलाइज्ड हॉस्पिटल्स हैं उसमें डेफिनेटली सर आपका अस्पताल लीड लेकर प्रिंसिपल सेक्रेटरी मेडिकल एजुकेशन के थ्रू इसमें आगे बढ़ सकता है। सर ने जैसा SGPGI में टेलीमेडिसिन हब पूरा एक डिपार्टमेंट ही सेटअप किया था। आई वाज आल्सो पार्ट ऑफ दैट। वो पूरी जर्नी में मैंने देखा उसको किस तरह से वो इवॉल्व हुआ। तो मेरे ख्याल से जो बेनिफिट उड़ीसा या जितने भी हमारे स्टेट्स के लोग ले रहे हैं PGI का, उस तरह का एक एनवायरनमेंट यहाँ पर भी हम लोग क्रिएट कर सकते हैं। एंड डेफिनेटली सर ये जो अभी जो रिसेंट घोषणा हुई है माननीय मुख्यमंत्री जी की, उसमें डेफिनेटली लोहिया इंस्टीट्यूट एक लीड ले सकते हैं। थैंक यू सो मच फॉर इनवाइटिंग मी।
थैंक यू। सबसे पहले जो बाहर से गेस्ट आए हुए उनका बहुत बहुत स्वागत आज के दिन पे लोहिया इंस्टीट्यूट में। सर के द्वारा जो इनिशिएटिव लिया गया है, आई थिंक कि दूसरे डिपार्टमेंट भी इसको अपने फील्ड में अप्लाई करेंगे और उनके फील्ड के लोग इससे बेनिफिटेड होंगे। जैसा कि जैन साहब अभी बता रहे थे कि मुख्यमंत्री जी बात कर रहे हैं टेलीमेडिसिन की, और जो ये अपेक्स इंस्टीट्यूशन है यूपी के, आरएमएल, केजीएमसी और एसजीपीजीआई, इनको हब बना के स्पोक के थ्रू डिफरेंट मेडिकल कॉलेजेस को जोड़ने का पहले उनका प्रयास है। जैसा कि सीएमए साहब ने बताया, पहले तो स्ट्रोक मैनेजमेंट में प्रयास है, और बाकी उसके बाद से डिफरेंट विधाओं में इसका हम यूज करेंगे। कोविड टाइम ने हमें सिखाया कि टेलीमेडिसिन कितना इम्पोर्टेंट है। हर एक आदमी बेसिकली, नॉट कि कोई जितने भी डॉक्टर्स हैं, हम सब टेलीमेडिसिन में बिजी है। हम सभी जो जिसको जितनी कैपेसिटी थी, सबने टेलीमेडिसिन को यूज किया फॉर ट्रीटिंग द पेशेंट। लेकिन एजुकेशन में इसका यूज उस स्केल पे नहीं हुआ जितना इसका पोटेंशियल है। हालांकि बहुत सारे कोर्सेज हैं स्टूडेंट्स के लिए, लेकिन मेडिकल एजुकेशन में उसका इतना यूज नहीं हुआ जितना हो सकता था, एक्सेप्ट कोविड टाइम। तो इसके लिए हमें सबको प्रयास करने की जरूरत है, और इसमें पोटेंशियल बहुत है। आने वाला दिन टेलीमेडिसिन और एआई का ही है। एआई के थ्रू और टेलीमेडिसिन के थ्रू हम मास को रीच कर सकते हैं। और जैसा बताया गया कि डॉक्टर पॉपुलेशन रेशियो इंडिया में काफी कम है, और उस डॉक्टर पॉपुलेशन रेशियो में भी पर्टिकुलरली डॉक्टर्स लाइक इंडोक्राइन सर्जन, न्यूरो सर्जन या न्यूरोलॉजिस्ट या सुपर स्पेशलिस्ट जो भी डॉक्टर्स हैं, वो और स्केर्स नंबर में हैं। तो उनकी सर्विसेज ऐसे ही रीच कर सकती है कि हम टेलीमेडिसिन को यूज करें और रिमोट प्लेस पे लोगों को हम ट्रेन करें। तो इसके लिए डिपार्टमेंट को बहुत बहुत बधाई एंड थैंक यू सर, आपने सोचा। हम बाकी डिपार्टमेंट इसको अपने फील्ड में यूज करेंगे। और इंस्टीट्यूट एक, मैंने सर से रिक्वेस्ट किया है पहले, अभी हम लोग उस पर काम कर नहीं पाए, बट जल्दी ही करेंगे। एक एसजीपीजीआई जैसा ही, या अगर सर चाहे तो उससे भी बेहतर, वो जो वहाँ की लर्निंग है, अगर वहाँ पे कोई शॉर्ट कमिंग है तो उसको भी हम दूर करके यहाँ पे एक वैसा ही टेलीमेडिसिन सेंटर जल्दी शुरू करेंगे। थैंक यू।
Sarah to give a thanks.
A fresh start is not a new place, it's a new mindset. And I have to thank Professor S.K. Mishra sir for this fresh start of our digital studio for collaborative e-learning, which is his brainchild. Thank you, sir, for giving us the opportunity to be a part of this new beginning. I would like to thank our Honorable Director, Professor C.M. Singh sir, for inaugurating the studio today and appreciating our efforts. I'm also grateful to CMS sir, Professor A.K. Singh sir, who has graced the occasion, and our guests from outside and the HODs who have participated in our inauguration. Thank you all so very much. I also cannot thank our department staff enough, who have worked really hard in setting up this studio, especially Akhil, Vikas, Yadav ji, Ashwarya, Pooja ji, all of you. Thank you so much, and all the staff for attending this. I also thank the Indian Association of Endocrine Surgeons for providing us the platform to begin our first activity of the digital studio, which is CME on totally implantable venous access devices, which we'll be starting shortly. Thank you, everyone.
Thank you for the investment.
To all the speakers and the participants and all the delegates who have joined us online, please give us some time. We'll be starting within 10 minutes with our CME. Thank you, everyone.
Yes. Yes.
Means I'll call you Abhishek. We'll start. Ishita.
स्टूडियो लाइट है बाकी रहने दो ये बंद कर दे टीवी लाइट है हां टीवी पे लाइट है अच्छा ठीक है ये समझे ले लाइट देखिए स्पीकर पे से बोलेंगे यस सर जब अनाउंस करो इशिता you start you have to come here to announcement दरवाजा
We'll now begin the CME on totally implantable venous access devices. To start the session, I would like to invite our convener, Professor S.K. Mishra, sir, from the Department of Endocrine Surgery, to give the opening remarks.
Thank you, Ishita. I welcome all the remote participants, all the faculties and all the academics from different colleges and hospitals, and our own department faculty, Dr. Savaratnam from SGPGI, and Arjun from King George Medical University, who are physically here. So, as you can understand, this is our first initiative, and you know this department is just evolving in terms of academic infrastructure and academic activities. So, we are much kind of delayed for start MCS program. So, however, we thought of taking the platform of IAES, so to reach out to intended learners to carry out some of these small activities in workshop, seminar, case discussion. Every month we do something, and for the benefit of people, and it's a collaborative way using all the internet and collaborative technologies. And we expect all the institutions and academic institutions particularly to collaborate with us to share their experiences and for the benefit of one and all. So with that remark, we launch this activity today, and I request our colleagues to carry it forward for the day, and organize secretary Dr. Sarah and co-organized secretary Dr. Abhishek, they all will be carrying out the entire activities for the half day. So I request all of you to see the feel the event, how it is, so that give your opinion, so that we can plan our things in the future, so that it will be more effective and more impactful. Thank you very much. So I request to carry out the proceeding of the day.
Thank you, sir, for setting the tone for the day. I would now like to introduce Dr. Arjun Raja, sir, Assistant Professor from Department of Endocrine Surgery, KGMU, who will be speaking on TIVAD overview and indication. Session will be chaired by Dr. Divya Daya ma'am from PGIMER, Chandigarh, who is present with us over Zoom call, and Professor Sabaratnam M. sir from SGPGIMS, Lucknow. Sir, please begin.
I thank Dr. Sarah for giving me an opportunity to present this topic this fine day. And I move with my topic. I'll be presenting on the overview and indications of chemoport in view of chemotherapy. As you all know, my name and designation has been already been told. Not going to. And the concept of chemoport was initially conceived in 1980s. It was mainly due to the recurrent infection and thrombosis that was present during while administering chemoports. Should I look into? Yeah. Recurrent infection and thrombosis, which was present during chemotherapy administration. And the first totally implantable central venous port system.
Do you need a pointer?
No idea. Where should I look into? Like
You should look there.
In the camera.
The first totally implantable central venous port system, which was called TICVPS, was designed in 1982. This all machines, which was made, which enabled the delivery of the high viscous chemo drugs and also which are the chemo drugs, which were known for its endothelial irritation causing and local tissue toxicity, which can be administered using with minimal mobility. Let's have a taste about some brief history of chemoport evolution. It all started with the use of cytotoxic therapy for malignancy. It was started in 1940s with the introduction of nitrogen mustard. So the thing with nitrogen mustard was that it was so tissue toxic. So even the administration by peripheral line, it caused a lot of morbidity. So initially, it was started giving to patients who had liver metastasis following with primary due to colorectal carcinoma. So initially, nitrogen mustard was tried in these kind of patients. So it started with they used initially polyethylene catheters for intra-arterial administration to hepatic artery. This hepatic artery gained a lot of popularity, and it slowly evolved into when it reached 1950s. This evolved into regional perfusion by making an extracorporeal circuit of that regional chemotherapy perfusion. And it was given to malignancies of extremities, chest, pelvis, and head and neck. And further evolution happened in the 1960s, where for fungal meningitis, the Ommaya, he designed a drug delivery system that can be implanted in the scalp, and it can be delivered directly to the cerebrospinal fluid. So then followed with the 1963 Watkins. He designed portable chronometric infusion pumps, which is basically an external reservoir will be there, which hold the chemotherapy, and which will be pumping into the chemo port in a slow rate, so that large volume of chemo drugs can be given while the patient can be like move around with it was a battery operated system. Until 1980, all this the evolution started from intra-arterial regional therapy, then loco-regional therapy, then came the concept of totally implantable drug delivery system, central veins. This was designed mainly for the purpose of those patients who needed multiple drug administration and the irritant, the chemo drugs, mainly chemo drugs, and heparin, insulin delivery. These were the reasons for the designing of these machines. So till 1982, Niederhuber, he was the first one. John Niederhuber from America, he started using chemo. He is a divisional head of surgical oncology. He started using chemoport. The picture on the left, this lady is wearing a chronometric chemotherapy delivery system, and in the front of the chest you can see that is the drug reservoir, and the lower part you can see a metallic, it is made of titanium, that's a chemoport. External part through which it will be delivered into the hepatic artery. To the right, showing the scalp drug delivery system. These are the prototypes, mainly how it evolved. So in the under the scalp there will be a reservoir, and it will be punctured with a needle, and after that we have to put manual pressure to push the drug into the lateral ventricle. So this is one of the first chemoports developed. This is totally implantable. There is no outside. The skin will be punctured from the outside into this lumen, and the catheter will take the medicine to the central veins. So the first implantation of chemoport, like even because at that time it was costly, it ranged from 2,800 to 3,000 US dollars. That much costly at that time. And of the first chemoport, how it was designed. So it was designed like made of titanium and stainless steel, containing two chambers. As you can see, there is a drug chamber and a charging fluid chamber. The drug chamber was around like 50 ml. You can store up to 50 ml of whatever it is, chemo drug or any blood products, whatever. And it is separated by a diaphragm. It's called bellow. It is expandable. And outside to it, it contains a charging fluid chamber, which contains freon gas. This freon gas is so peculiar that it can expand with body heat. So what happens is when the drug is introduced into the chamber, it will cause the compression of the bellow. So the freon will get compressed and absorbing the body heat. After over some just say a half an hour, the drug will get pushed slowly into the venous vascular system. This is how the initial chemoport worked. And it was made as a dual pump. Dual pump means that there is one more auxiliary port where we can cannulate and inject directly without the slow delivery system directly into the vein itself. So in this picture, you can see this is John Niederhuber, who is the head of division of surgical oncology in MD Anderson Hospital. He started using chemo, the modern chemo ports in 1982 for hepatic match patient following primary colorectal carcinoma. And it was the same chemo port was actually it was initially designed for the delivery of heparin. It was designed by the University of Minnesota Biomedical Engineering Department for Administration of Heparin, which was the initial purpose. Then it was adopted to the oncology side and started giving for you started using to give chemotherapy. The implantation, now we don't take that much time we don't have that much duration. The first surgery to implant the chemoport took around 10 to 12 days, the total duration to implant and discharge the patient. Now it's like hardly 1 day. Then it's the indication. So the current indications of the use of chemoport is for administering chemotherapeutic drugs or any blood products or parenteral nutrition. It can also be used for venous sampling so that multiple frequent punctures can be avoided. This is my conclusion side, and thank you. Thank you.
Thank you, sir, for that insightful presentation. And thank you to the chairpersons for guiding the session. I would now like to introduce Dr. Pooja Ramakant, ma'am, professor from KGMU, who will be discussing TIVAD technical aspects, complications, and their management virtually. This session will be chaired by Dr. Divya Daya, ma'am, and Professor Gyanchand, sir.
Thank you, Sarah. Am I audible and should I start?
Yes, ma'am.
Sure. Thank you, Arun, also. I thank Mishra, sir, for this beautiful initiative of collaboration and technology. So, with this, and Sarah and Abhishek for talking to us and for helping us to collaborate and to have a joint session and also to do under the aegis of IAS. So I shall be talking about the technical aspects. What are the problems or we can anticipate when we start doing chemoport insertions? And second thing, before I begin, I will also say that we have to plan everything. So for every step, we have to deconstruct the step, make it into small micro steps, and then work on those micro steps to expertise it and not to make any tiny mistake. So I begin with patient position and planning of the incision. So patient should be lying down supine with the neck slightly lower down head end, like a Trendelenburg position, so that the IJV is filled with blood and it is more dilated, so it is easy to insert the needle in it. Plus head is tilted towards the contralateral side. You mark the clavicle and the sternal and the clavicular heads of the sternocleidomastoid to look for the IJV. Sometimes in anatomical variations, IJV is usually superior to the artery, but sometimes we have to be prepared for any abnormalities. Mark your incision, like in this patient also you see the pocket is slightly more medial. It should have been more lateral. So all these plannings can happen if we mark it well in advance. We have to ensure that we don't cause any source of infection to go in the chemo port, and unfortunately, if we have to take it out if the infections happen. So we have to ensure all sterile precautions and give the antibiotics well before the procedure begins. Once you are planning for the chest wall pocket, you see mostly it's on the second rib. Plan the incision on the rib. See there is cuff of fat present above the pocket when you plan it. If the patient is too thinned out, deviated, but assure that, like in these photos I have shown, there should be no thinning. The port should be palpated, not being seen on inspection. So then it goes wrong. And I've seen the skin thinning out, and finally skin gives away, the port is visible, and then that's a source of infection happens, and then we have to pull this chemo port out. So all these things should not happen. If the patient is too fatty, then use a C-arm to plan your incision, plan your depth, because if you plan it up to the pectoral fascia and too much of fat is there, then when you insert your needle, Hubbard's needle, then you may have problem in inserting, because needle is small and it has a well-defined measurable length of insertion. Port must be planned below the incision line, so it should not be on the incision line. So that also part we have to take care of, and it should not be medial so that there is no acute angulation which is happening. Then you plan to give the local anesthesia. Always check the sensitivity. Patient is not allergic to it. I've seen once anaphylactic reaction happening, patient finally going in the ICU because of that reaction. Even before we could start the procedure, that unfortunate event happened. Then use a 26 gauge needle, the thinnest possible needle, or the insulin syringe to give the local anesthesia, so that patient should not experience any pain or discomfort. If patient is confident that patient will not have pain throughout the procedure because this is done under local anesthesia, then only patient will be cooperative throughout the procedure. So that part we have to ensure. Then you identify the IJV using the ultrasound. So we have to be well versed using the ultrasound. It is usually more oval. Then check the chemo port, the TIVAD box. See everything is well placed and everything is working well. Flush everything with the heparin. And you have to flush, have the betadine ready. You mix it with saline. Ensure some centers they use only saline, so you have to follow the protocol which you are doing it, and flush everything, even the guide wires with the heparin, so that there's no blockage happening. And you also check that everything is working well. The dilator is working well, everything is working well. So plan everything in advance before you do the steps. Then you take the ultrasound and you plan for the IJV identification. Please cover the whole probe along with the wire of the ultrasound, also with the sterile things. Even small mistakes, if we don't cover it, then they may act as a source of infection, and then post-operatively patient may develop infection. So we have to lubricate it. We have to identify the IJV using the ultrasound, insert your needle. Once we didn't use ultrasound, then we were more in the flat acute and in the flat angle. But now with the ultrasound, that angulation doesn't matter much. Then if you press too hard on the ultrasound probe, the IJV gets compressed. You may not even to identify, like in this picture it has happened. So how much pressure you give with the ultrasound, that also is important. And that once we start doing it, we start realizing with time that we have to release little bit of extra pressure which we have given, then only the vein is more visible. So take adequate time to identify so that we don't puncture the carotid. Once you have inserted inside the vein, you see the tip of the metallic, your needle is seen inside the vein. You aspirate it, you see the dark blood is there. It is not a bright red blood of the carotid. So you confirm that. And then you insert the guide wire. And then you have to little bit extend the incision of the neck because we have to dilate it. So using the peelable sheet, you insert it. You see that there's no resistance happening. On the right side, the vein is straight, so it is easy. On the left side, we have to be careful because the vein turns towards the right side. So you insert it and then see that the incision is adequate and it is going freely. So that means there is no obstruction in the vein. Then you insert the catheter. So this catheter has to go till the superior vena cava. It should not be going in the heart. That we have to be careful. So there is marking in this blue catheter and it should be around 16 to 17 centimeters inside. So you can use a C-arm. If it is too much inside, you can take it out. So have the gadgets to help you. And then you plan the pocket incision. You give the incision and you go to the pectoral fascia. Don't give too broad incision because that causes more seroma formation and risk of infection. Once you have made your pocket, you see there's a cuff of fat enough so that there's no thinning happens. You make the pocket with your finger. You can dilate the space with your finger, lower down below your incision. Then this is an important step where all the eyes, there are 4 eyes where you can insert the victal suture or non-absorbable suture, whatever you want, before you insert this chemoport. So then you just have to suture the pectoral fascia. If you don't do this step, lower down when you are doing this step, inserting it, the needle bends and then you struggle with the small space inserting in the eye. So it is better you have 4 victal sutures, 4 independent in all the 4 eyes. So you just have to fix it. Then planning for the tunneling, you insert local anesthesia, again give it in the tunnel so that patient doesn't have pain. And you insert the tunnel and see the tunnel is in the subcutaneous plane, not too deep, not too thin. And once you come towards the neck, ensure that the incision is enough so that the tunnel comes out of it. If it is too thin, don't struggle for it. You may have to modify a little bit and increase the length of the incision if you feel you are struggling to come out of it. And then it should not be too, not in the intradermal space or not too deep. So that way you can plan it. And then once you have inserted your tunnel comes out, you insert your catheter in that. There's a small tiny thing where the black hole should be towards the body. So that part is to be taken care of. And then you take out this blue catheter and ensure that it doesn't leave behind in middle. If you don't insert the blue thing, the tip on that well. So you take it out. You can cut the extra. You insert the guide wire, the black wire, this metallic wire, so that if you have to reposition it, then you have the something to hold and pull it back and readjust. Sometimes kinking happens, so you can readjust if you want to. You can see the markings like 20 or 18 or something, and then you can readjust the length if you need it. So you can just pull it out and ensure that there is no kinking happening at this point. This is a very important step. And once it has gone well inside, you can just remove it so that there's no twisting or kinking happening. So you cut the extra tip of the catheter and you insert then the chemoport. And again, you have to ensure that when you insert it, don't insert half-heartedly, so that otherwise it will come out later on. The port can go dislocate, and then you insert it well till the end, and then you pluck it with the plastic which you have, and then you insert the heparinized saline and see that the blood is flowing well, and then you flush it back with the heparinized saline. So once it is working well, you can insert it and fix it once everything is in place. So once you are fixing it, see that your port doesn't get kinked again. So kinking should not happen. And then you start doing the closure and seeing there's no kinking. If there's two extra catheter is there, you may have to revise your length. If it is too, it should not be too small or too large. Then use the C-arm to check the position of the catheter. It should not go beyond SCB. If it has gone to a heart, it may cause arrhythmias. If it is above the SVC in the IJV, it is too above, then there are chances of thrombosis happening when you are giving the chemotherapy. You can do a chest X-ray also to see, like for example, in this, there's a kinking in lower part and the port is too placed lower down and it is a bit medially. So you see upper end also is slightly angulated. So it should be all smooth angles, no acute angulations. Then the chemotherapy drug, if you administer, then it will have struggle in going down. And this is also too thin. So all these corrections, you can make it using a C-arm. If you don't have a C-arm, you can do a simple chest X-ray and you can revise your steps accordingly. So compared to the right side and left side and the IJV and the subclavian methods of insertions of TIVADs, right, IJV is the easiest. And if there's a problem happening, you can compress in the neck. Left is slightly difficult because the wire can go up on the right side. So to avoid that happening, you can flush it throughout repeatedly once you are inserting it continuously. So it flows with the gravity downward and not goes up and goes in the right IJV. So that part is taken care of. and right subclavian or left subclavian if you're planning it, if you are comfortable putting in the subclavian. The only problems is that there's higher chance of pneumothorax happening because the apex of the lung is there. There's no space to compress if you cause multiple punctures or the bleeding happens. So that is a difficult, but some people are comfortable putting in the subclavian. So right side is easy, left side we have to be extra careful. So we have to be well versed with the anatomy part. So summarizing, we have to plan and deconstruct each step well, anticipate if any step goes wrong, we should identify and revise and mend it on time. We should not ignore it or not be able to identify. That should not happen. We should know the complications which can happen, like extravasation of chemotherapy can happen if we are not well versed in using the Huber's needle. There should be no kinking, like I've given you examples how kinking can happen. Catheter should not get dislodged, or there should no flipping of the catheter chemoport happening. There should be no infection happening, especially in diabetic patients. We have to be very careful. Cancer patients have immunocompromised state, so we have to ensure all sterile precautions, ensure that there is no hematoma or thrombus happening, and be careful when we would use subclavian that there should be no pneumothorax. If that has happened, then we should be prepared and insert the ICD, but we have to identify and recognize the complications. So with this, I end, and I'm happy to answer any questions if somebody has any comments. Thank you.
Thank you, ma'am. And thank you to our chairpersons. All questions or queries are now welcome.
Thank you, Dr. Pooja and Dr. Arjun, for the nice presentation. So I invite any questions from any of the residents if they have.
Pooja ma'am, very nice presentation, Sabha here actually. Hello ma'am. Actually, in case of youngsters learning to put the chemo port, even in a left-sided disease, will you, if there is if it's a right-sided disease, still sometimes, is it better to put the chemo port on the right side rather than adventuring on the left side?
Yes, Sabha, you have raised a very important point. It's not that it's absolute contraindication. We can put on right side. We have to be careful if we are doing mastectomy. We don't, by raising the flap, we have to be careful because it is anyway on the second rib. If you are planning breast conservation and the cancer lump is on the other quadrants, not in the medial side or the upper that way, if it is not exactly on that, then we can put it. Left is slightly more tricky. So we have to rehearse more on right sides and then start experimenting on the left side. I agree that part.
Thank you, ma'am. And another thing is how many of your patients, when they are getting initial upfront surgery, get chemo port or TIVAD implanted at the same time?
That option is always there, but problem is with us, the problem is with the anesthesia time. We don't want to lose that anesthesia time. So we plan it separately, not club it in the general anesthesia list. But if patient is very hesitant and request or something, then out of the way we may do it, but not as a routine. But that is also a good practice. If we do under general anesthesia, that same things happen.
Thank you, ma'am.
So,
Anybody else? Next, I would like to introduce Dr. Dilip Ramesh Hoysal, sir, from TMH Mumbai, who is present with us on Zoom call and has a video demonstration on TIVAD insertion. This session will be chaired by Dr. Pooja Ramakant ma'am and Professor Sabaratnam M. Sir. Sir, please go ahead.
Is my slides visible?
Yes, sir.
Good morning, everyone. Good morning, Sabha sir and Gyan sir and Pooja ma'am. Thank you, Sarah and everyone for the wonderful Abhishek sir for the opportunity for presenting this chemo port, which is a day-to-day for all of us and a bread and butter for the surgeons in the coming days. So now, Pooja ma'am has done a wonderful job. It has really reduced my workload here. So I am just going to deal only with the video demonstration. We had a one second, sir. I just want to minimize this. Yeah, we had a 56-year-old postmenopausal lady who was planned for a initial upfront surgery, who was left early breast cancer 883 plus fish was amplified, and we took her up for it was a left BCS. Sorry, I'm extremely sorry. Where we did a left BCS and an axillary clearance and a right chemoport insertion, which was done on 28th of February. So, madam has told regarding the patient position. Patient is supine with arms by the side, neck extended, sandbag behind the shoulder, head slightly tilted towards the opposite side. Let's directly get on with the video. So this I have used a BART port, which was a sample for the patient. So we open it with sterile precautions, take it out, put it on the sterile trolley. Open up the package, start flushing all the parts, as madam rightly said, that you have to flush all the parts. Why do we do it? It is to make sure that none of them are malfunctioning. So that is the venipuncture needle which we use for puncturing the IJV. That's the heparin flush, which is used to flush all the this one. The heparin flush is about 100 units per ml. So that's the dilator with the sheath. The white one is the dilator and the gray one is the sheath. Now we have the catheter, the blue catheter, the Groshonks. It is called as the Groshong catheter. There are multiple catheters there in the market. With the most commonly that we use is the Groshonks. That's the non-core Hoover's needle. So that's the port hub, which we will be flushing. All the instruments in the port tray needs to be flushed. There are two things which are really important in this tray. One is the gray sheath and the hub connector, the two plastic piece. Those two are very important. So I use a 2cc syringe for a venipuncture because it has got least resistance, and if I'm in the carotid, it gets automatically filled. So I need not aspirate anything. So that's the connector, which is very important. Please be sure that you do not drop it down. And that's the guide wire and the tunneler. So we may mark the patient. That's the suprasternal notch. That's the clavicle. And that's the lateral crease or the anterior axillary line when you draw it upwards. Do not go beyond that, because once the patient starts moving her limb, the port will get dislodged. A 2-finger bit down, that is at around the second rib, where you and try to keep it as lateral as possible so that you do not get that medial kink when you put it medially. Now use the ultrasound. Make sure your probe is correctly placed. Now I had kept it ulta, so I've made it proper so that we see the right side IJV on the right side of the trachea. So the probe position should be exactly where we want it to be. So the compressible one is the IJV. The one which is round is the carotid. So 1 finger breadth be above the clavicle, where we would like to puncture and go into the IJV at an angle of 45 degrees. Yeah. So you will see me doing a jerky movement at the entry point to see where exactly it is coming. You will see these jerky movements being done. You can see that jerky movements to see on the ultrasound where exactly I'm entering and how my course of the needle is going to be. So once I do that, I know where I'm going and I do the puncture and go in slowly, bit by bit, bit by bit. The pressure by the assistant should not be too much, otherwise the entire wall will collapse and you will do the through and through puncture. Now you can see the needle in this one, and it is also come in the syringe. The syringe probably is not well seen, but it is there in the, yeah. So there is a free flow, there is no spurter. If you are in the carotid, there will be a spurt. So when you remove the needle, so look for a free flow, which is not a spurter. Then insert the guide wire slowly. Insert the guide wire. The right hand, that is, I'm a left-handed surgeon, so the non-dominant hand should be as steady as possible. It should be very, very steady. You should not be moving your non-dominant hand. So that will actually support everything. So now once the guide wire is in, you can actually listen to a beep, which comes on screen. If you can see, there is a ectopic here after the third beat. So that is what is you actually feel when you get into the, when you hit the right atrium. So remove the needle, remove the ultrasound probe, check it with the C-arm once again to make sure that it is in the right place. It is just double checking, using tools to just make sure that you are in the right plane. So pull the breast as down as possible so that you are not unnecessarily putting it somewhere lower down. When the patient actually sits up, it is tending to drag the port also down. So you make a small incision so that you can get the dilator in. So now that's the dilator going in. So you should hold the guide wire at all times. So do not just push the dilator with the guide wire, otherwise guide wire is going to go in. It has happened. So please make sure that you hold your guide wire at all points of time. Take out the guide once the dilator and the sheath is in. Look for the free flow again. Now the catheter. Catheter goes in, the dilator comes out, the catheter goes into the sheath. So slowly push it in. So once you're pushed in, start peeling off the sheath. Now it is just like breaking your Kit Kat. So you just have to break it like that. Yeah, it just opens up. Yeah. Slowly, the assistant has to hold the catheter in place so that it doesn't come out along with the sheath while peeling off the sheath. So now hold the breast down, take 2-finger gap, press the lateral chest wall incision, go up to the pectoralis fascia. Do not fix it to the fat. It is going to get migrated. Go to the chest wall, go to the clavipectoral fascia, fix it to the fascia and the muscle. So your pocket should be just adequate. You can see that it is just adequate, and I've nicely tunneled it under, and the port cavity is not at the incision site, it is below the site. So take the first bite deep inside. Yeah. So This is where we fix the 3 points. It's the 3-point fixation of the port. And now, once that is done, you will have to tunnel the catheter through the subcutaneous plane. So remove that guide wire which is there in the catheter, and you have to also remember that you shouldn't push it too deep so that white thing is just sitting at the skin. The blue catheter will go inside the heart, inside the vein and into the heart. So now you have connected the tunneler there. So pull the guide wire up to the marking, pull the catheter up to the marking where it is numbered, and use the guide wire so that you can manipulate the catheter later on to adjust its position. So that's, you need to be subplatysmal when you are in the neck and subcutaneous when as soon as you cross the clavicle. So, and you reach the port. So it can be done either ways. You can either push it from below upwards or above downwards. So now I'll start positioning the catheter tip. So tip is the tunneler tip is cut from the catheter and catheter is made free. So now we'll start pulling the tip of the catheter to place the catheter in its position. Now I'm pulling slowly so as along with the C-arm guidance. Now if you can see that catheter going there into the heart, we need to keep pulling out. Now after a point of time, we will start seeing the markings, and usually on the right side it is around 9 to 11 when you are exactly around a couple of centimeters from the clavicle. So you can now start making, you can make out that it is fluttering. So in the heart, the tip flutter centimeters. So it is at 10 centimeters. So that is the bifurcation to right trachea, right bronchus and the left bronchus. Your tip should be just behind or anterior to the bronchus. So between the superior wall of the bronchus and the inferior wall of the bronchus. So slowly, once you've fixed the position, pull the catheter on the distal end. But just make sure that there is no kink when you're pulling the catheter. And that's the hub which I told, which is very important. You can see a black line there, that is black towards body, B for B. So once you've inserted there, measure how much it is needed for it to go in, and just right at that point, just cut it and insert it to the port. So I'm avoiding to use any instrument so that I do not damage the Grosjean catheter. Grosjean catheters are very, very friable. They are very, this one. Try and avoid using an instrument, but if you have to use a plain forceps, not a tooth forceps or any other forceps which has sharp tooth. Now what I use is a Debicki's forceps, vascular forceps, if at all, if I have to. So now I'm fixing the chemo port on the chest wall at all places. Parachuting, that's what we call when you take down the sutures to the place where you have to suture them. So once the port is in place, check with the C-arm again to check with the tip. Again, you can see the tip is at the right bronchus. Okay, in the right, just at the level of the right bronchus. So now aspirate and check for the flow. Free flow and free forward flow and free backward flow. Do not inject any air. And make sure your flush is completely filled with heparin saline, clear saline, so that you do not give rise to any thrombus or any infection. So once that done, I have rechecked it and I'm going to pull out the guide wire from that position. So I usually take this bite myself because you might injure or puncture the catheter when you're taking this bite from uh, to the underlying catheter. So just be very, very superficial, and also to make sure that there is no ooze coming out of that. So wound is closed in 2 layers so as to make sure that the port is completely separated out from the surface. So this was the detachable port that I have done. So I have another video which is a pre-attached port, and this side it is on the left side. So I've also included a left port here. So again, on the left side, you can see that the IJV is left to the trachea. And I'll just, yeah. So again, a puncture on the IJV just to probe it and enter the IJV. So I'll be a little quicker here. So this part. So once that is done, this part I was unable to show you properly, the pushing the guide wire there, because it was not clearly visible in that video. So you just have to push it when the guide wire is entering into the right side. So there is a mild resistance felt always. So that is, you should realize, and you should not force yourself when you're inserting or pushing the guide wire. You can end up going to any place. So we have had a right subclavian entry, right IJV entry. So we need to be very, very careful when you're doing a left hemoport. So now this is a pre-attached hemoport. So in here we actually put the dilator. Now that's the confirmation using C-arm. Now in a pre-attached port, what we usually do is, take the incision first itself without putting the dilator into the IJV. We dilate. We make the incision, open the wound, open in layers, go up to the pectoralis fascia. I think in this video, we'll be able to see that I have gone till the pectoralis fascia. Yeah, so now we can see that the pectoralis fascia is there, and just below that is the muscle. So you fix it to that layer. So this is a pre-attached port. You have a tunneler coming in from below, and you open it into the neck wound and pull the catheter. So entire thing is fixed. All you have to do is now fix the port here itself, and then push the catheter into the IJV. So I'll just speed up this thing. So it is just nothing but fixing the port. So all of them are getting fixed. So once the port is done, so again recheck for your guide wire, position of your guide wire. So now I'll measure the length of the catheter that needs to be cut. I've kept an instrument at the level where I want it to be, and I'll cut the catheter at that point of time, at that particular place. Now pushing the dilator in, and I'm always holding the guide wire at all times. Putting the dilator in, I'm holding the guide wire at all times. So this is how when the dilator goes in looks. And behind you can see the mobile one is the catheter that I have cut. Now the guide wire is out, the dilator is out, only the sheath is remaining. Now that is the cut end of the catheter which goes in. So this part is a little tricky because you need to keep pushing the catheter inside and pulling the sheath outside. So the index finger will always just like pushing your knot. Push it using your index finger and pull it out using your thumb fingers on either sides. Yeah. So this is the last chemo port C-arm that I've taken for the left sided. So now I check for the patency, forward flow, backward flow. This is not a valved catheter, so you will continuously have this dripping of blood coming out through that hub if you keep the hub in place. So check for hemostasis, make sure that there is no hematoma inside, there's no bleeders inside. Hematoma can get infected and your entire procedure is going to go waste if you have to explant the chemo port. So yeah, so chemo port insertion is a procedure with multiple smaller important steps which need attention to detail. It's very, very important that you give each and every step that amount of importance and make sure that you do not go wrong. Even if you're going wrong, then you have to rectify it and go ahead with it. So thanks to my team at TMC and humble pranams to my teacher, Professor Mishra sir, Sabha sir, Gyan sir, every one of them who have taught me. I've learned my chemo ports from Abhishek sir, to be very, very frank. And that's how it happens. And I got one nice picture here, which I present, which I went, this is a photo of a presentation for open adrenalectomy that I did in December 2022. Sabha sir has been extremely supportive for all the young surgeons like us to make sure that we go and present in all of these conferences. And one special thanks I want to say is to this person, that is Sister Amrita, with whom I did my first independent chemo port. So this is greetings from Tata Memorial. And now I've recently we have a few of the TMH consultants are moving to ACTREC because they want to develop ACTREC as a new hub bigger than TMH, which is about 1,200 bed hospital. I would be happy to take any questions.
Thank you, Dilip. You have wonderfully demonstrated and highlighted each and every important step and gave the importance of all micro steps, identifying the problems and mending it, and also taking care that what problems we may anticipate and be careful. And it is a very important step to put a chemo port because every small mistake can lead to disasters. So I'm open to the house for any questions on site or online people. Anybody has any doubts or any comments?
Yes, ma'am, I would like to ask a few questions to Dilip sir.
Sure.
So thank you.
सारा इतना तो पूछ लिया है पीजीआई में और क्या पूछेगी चलो सॉरी go ahead.
Thank you so much for the lovely videos, for the video demonstrations. I saw that you used power port for the right-sided TIVAD insertion. So how does that fare better than the others? Any
No, it is the
advantages?
same. It is just that if at all, if you have to do an MR or a CT, they use infusion pumps. So for which you need that extra bit of pressure, that some, I think it is that 200 PSI or something which is needed. So that you cannot do it with your regular chemo port. So for that, you will have to again take another vein IV line. So in that way, the power port helps. And with the rate contracts we have, it is more or less the same amount that we have the patient has to pay. So and that's the reason why we go ahead with a power port.
And you have used many different kinds of techniques to become master of chemo port insertion. What was the other brand that you were using? I've never seen that port.
That actually has gone out of production now. The pre-attached one has gone out of production now. So I think it won't be available anywhere. But I really wanted to show that this was there because even when I was in PJ, I never got an opportunity to see this. Or probably Abhishek sir or even before that, Sunil sir and Nitish sir might have seen that, but I have never seen such a port. When I came to Tata, I saw that it was like this. So, I was like, कि क्या हो रहा है? I don't know how to use this. Then it just took about 1 or 2 cases for me to get used to it. Because हमने इतना कीमोपोर्ट करते हैं PGI में कि here when I came in Tata, they were hardly doing it. Probably till the time I came, it was around 150 to 200 which is done. Now we have done about 600 to 700 cases in a couple of years.
Yeah, Dilip, a very good presentation, nice presentation, and I have
Sir,
you have told that
sir, credit तो आप ही को जाता है, sir. It is you, Nitish sir, who has taught us.
Credit goes to everyone who has taught us, especially
Yes,
our professors.
Very true, sir.
They taught us. No one has learned on their own. So you told that we might have used that prefixed chemoport. Even I have not used that chemoport, but I have removed quite a number of them. But I have never used. I have a couple of questions.
Yeah.
Firstly, what is your protocol if you just in case if you hit a carotid on your puncture? Then
Sir, whenever I hit a carotid, I keep compression and pray to God that it doesn't bleed. So
no, I want to, yeah, that's okay. I want to ask whether
I
you.
I did pray at one instance. I did
remember
pray at
that.
one instance. Sorry, sir.
Yeah, please go on.
I remove it immediately and keep a compression for about 10 minutes and just pray that it doesn't develop into an hematoma. So
no, whether you go ahead with the chemoport or you stop, abandon the process, and then.
No, I go ahead with chemoport insertion, sir. Wait for 10 minutes, see if there is no expanding hematoma, go ahead with chemoport.
Okay. Secondly, I want to ask, like on the right side, even if we don't have a CM guidance, like we used to have for some point of time in SGPGI initially, are there any specific landmarks, surface landmarks by which you can measure the approximate length which should go inside?
So sternal angle use करते हैं. Sternal angle we used to use it, and you yourself have taught me this. Sternal angle use करो. It's about 9 to 10 centimeters from there, and we are good to go. And most of the times you are correct. You are 7 out of 10 times correct with that particular landmark. But in this era of imaging technology, अगर कुछ medico legal होता है, so even if you and your hospital has this facility, why have you not used it? So I think that's a very important point. So we start using these image guided things. So जब हम blind करते थे, we would take multiple punches for an IJV. Now we can just do it with one puncher when you have an ultrasound with you. So if you have a facility, why not use it?
Yes, obviously we should use it. I saw a comment. Dr. Sanjay had told that he's regularly using. Sanjay sir, are you online?
Hello.
Sanjay sir.
Sanjay,
Sir, which one are you using commonly? You told
the non-detachable one.
Yeah, so you are using it.
Slightly cheaper, no? So
it is slightly cheaper.
Yeah, it is cheaper. So we commonly use that one only.
But don't you find that a bit tricky as compared to the detachable means?
Yeah, obviously the detachable one is what I say is type of luxury we cannot afford.
So if you said this thing, then we don't have any further questions for that.
So, Dr. Dilip, thank you so much for showing us the wonderful videos.
Sir, good morning, sir. Gyan sir, I'm not able to see you in this picture, sir. I'm really sorry, sir. Gyan sir. Sir, good morning, sir.
Just I want to know for the beginners, what is the ideal time to insert this chemoport once the patients first time come to your OPD, when you advise them to go for the chemoport?
Sir, whenever we have made the plan of chemotherapy, we can do it. For beginners, it is best to do it under GA when the patient and you are going to take some time to learn it. So I think it will take about, as a beginner, it will take up to 45 minutes to 1 hour for your first chemoport to go in. As you improve, it will come down to 15 minutes or even less than that. But till then, do it under GA as long as you are able to do it.
What is the learning curve for this chemoport insertion?
Sir, पता नहीं sir, जब तक I could understand it, I had already learnt it. I'm being very frank, sir. I'm sorry.
I think around 5 to 10, sir, at least.
Five,
Left side.
I think first हमें पंचर मिलता था 10 के बाद ही. This I remember because Nitish sir had not given me a puncher. Vishwak had not given me a puncher until I had assisted 10.
Thank you so much.
Dr. Dilip, actually, thank you for this wonderful talk, extremely useful presentation. Two things, like you showed a PowerPoint from a power packed institute, actually, and congratulations on being made an associate professor. Actually, I could
Thank you so much,
see
sir.
Okay. I like you said that it is useful when we are doing MRI sensitivities when this like these procedures. Now, do you in Tata use double reservoir ports or double ports where for chemotherapy and stem cell therapies, one port is used for single drug, the other port is used for transfusions and things like that. That's in vogue now. So, what's your take on that?
Sir, as far as I know, I don't think we are using any. Apart from us, the pediatric surgeon also puts a chemo port here, and the IR team puts a chemo port here. From both the sources, as far as I know, we still have not used these dual chemo ports, मतलब double reservoir chemo ports. But I will definitely ask them, go back, ask them, find out if they had really tried it earlier.
Thank you so much. Very nice.
So we are working. Yes.
Thank you, sir, for that detailed demonstration. And thank you to our chairpersons.
Thank you.
As you're running behind schedule a little bit, we'll have a working tea. Moving on to our next session on TIVAD maintenance and removal, I would like to invite Dr. Ganesh Bhatt, sir, on Zoom call, professor from the Department of Endocrine Surgery, CFI, to share his insights with us. This session will be chaired by Professor Gyanchand, sir, and Professor Kulranjan Singh, sir, from KGMU, who's present with us on Zoom call.
Hello, everybody. I am Dr. Ganesh. I'm currently working in UPMS FI as an associate professor. The topic for today's presentation is maintenance and removal of chemoports, TIVADs. I was told that the session was after tea break, and I thought it would be a good idea because inserting a chemoport is fun, but maintaining it is kind of a lifelong procedure, and we attribute it to be done by sisters. But it is equally important because if it's not maintained well, it's not going to survive. It's not going to serve the patient. So the functional status of TIVAD depends on the structural design of the chemoport that you're using, the implantation technique, and the maintenance. The overall complication rate is as high as 12.5%. There are some papers which say it's as high as 25%. And proper catheter maintenance is necessary to avoid these complications. What was initially thought was because both are central venous access devices, TIVAD and central line should have similar monitoring maintenance protocols. But it doesn't work so because the biophysics behind the two devices are different. A central line just has a laminar flow, whereas because TIVAD is a closed system, it has a vortex flow here and it has a laminar flow in the catheter part. So because of this additional component, the maintenance is going to be very different and it has to be respected. Coming to how you begin approaching the chemoport, first and most important thing is site preparation. First thing you do is you look for redness, tenderness, warmth, swelling in the area of where the chemoport is present. You have to maintain hand hygiene before and after palpating the catheter site, before and after inserting or replacing, accessing, repairing, or dressing any intravascular catheter. So this is very important, which is often forgotten in a busy chemo suit. It's very important to wear sterile gloves. They even recommend gowns and masks. Position of the patient is important from site preparation point of view because the head of the patient should be turned to the opposite side to avoid contamination from if the patient coughs or sneezes or something. It is ideal to use a 2% chlorhexidine based solution. basic the way we drape a part, painting and draping is done. This painting, it's mentioned that it should be done at least twice, and it should be left for at least 30 seconds. So this is what is recommended in most of the nursing guidelines that I could see. It should not be wiped away. It should be allowed to air dry. And the maximum treatment area is around 5 into 5 centimeters. So it's approximately 130 centimeters square. An aseptic non-touch technique is also mentioned. Here they have introduced the concept of key part and key site, and these two sites should be protected. Key site is any portal of entry into the patient. So the port at which the septum at which you enter the needle is the key site. And key part is basically the syringe strip, the drip set, and the needle, syringes, etc., which will enter the septum. There are three fields that have been mentioned. General aseptic field, which is the decontaminated and disinfected procedure tray. Critical aseptic field is a sterile drape or barrier used to ensure that there is asepsis, and a microcritical aseptic field, where a small protective sterile surface that, such as a cover of a syringe or needle or something. Coming to how do you access a chemo port, you can use local anesthesia because it is going to be painful for the patient. Some people use topical patches. You have to prime the needle with whichever, preferably NS, before you insert it. You have to palpate the base, usually a 3-finger. I'm sorry, I think can you see my slide? No.
No.
I think Meghna started sharing it. Yeah, is it visible now?
Yes, no.
Thank you. So you palpate the base of the chemo port using a 3-finger technique, and you stabilize it, and then you insert the human needle vertically so that it enters the septum. And using a 10 ml or bigger syringe. So never use a smaller syringe. Smaller syringe doesn't mean that the pressure is low. It is going to cause a higher pressure. So always use a 10 ml or a bigger syringe to aspirate. If you see the blood being aspirated, it's called as flashback. And then you gently flush with NS. Then you stabilize the needle and you appropriately dress the needle. What is special about this needle? This is called as a Huber needle, which is used to assess a port. It is a non-coring needle. And what does non-coring mean? It's specially designed to prevent the damage to the septum. So it is flattened or offset bevel. So what it means is the hole is not at the tip of the needle. It is at the side of the needle. So if you use a regular needle, some part of the silicone of the septum can get damaged. And these small microsilicon particles can even enter into the catheter and cause blockage of the catheter. So that's why you use a non-coring needle, and this will slice rather than puncturing the septum. There are various lengths and diameters of non-coring needles available. It can be from 19 to 22 gauge, and it can be 15 to 25 millimeters in length. It can be straight or angled or winged or with Y-side. The basic idea is use the smallest possible, because the smaller you use, the less damage it will cause to the septum, and the longer the life of the port is going to be. Whenever you use a needle, let's say if the patient is on continuous infusion, or if the patient is admitted and needs care for, let's say, total parenteral nutrition or blood transfusions, the needle has to be replaced every 7 days at least, or if there's any other indication. There are some studies which have said that it can be kept for several weeks, but I think it's better to remove it at least once in 7 days. And if you're using it for blood products, it is advised that it should be replaced within 24 hours. So these are some of the indications, as in the size of the needle recommendation with the drug that you're going to infuse. Also, chemo ports for breast cancer is usually put in the chest, but then they can be femoral ones, there can be peritoneal chemo ports as well. So the longer length needles you'll need for various special conditions. And what is important is the orientation at which you insert the needle. So when the non-coring needle is inserted into the injection chamber, at the middle part of the silicone diaphragm, with a 180-degree orientation. That is when you'll get the best irrigation. So I'll tell you what 180-degree orientation is. And the vortex flow within the injection chamber depends on the orientation of the non-coring needle. So that is why this is important. So it is not that if it's what we use is butterfly. So butterfly can rotate in any direction once you insert it. So it's necessary to make sure that it is inserted in the right direction and it's held securely in that particular direction. Also, it is inserted till you hit the base of the chemo port. But if you put a lot of pressure, there can be leakage, there can be pain during removal because the tip of the needle is going to get bent. So when you are removing this out of the skin, it's going to cause a lot of pain to the patient. So you have to be gentle here. And also what is important is you should vary the puncture site. So what many sisters do is, because there's a small scar of the previous needle inserted, they try to use the same scar site, try to enter the chemo port. First of all, the success rate of that is going to be different because it's important to stabilize the chemo port. And sometimes it can even damage it. And let's say you're lucky and you keep entering the same hole in the septum. That is also going to cause a lot of damage to the septum. So when a company states that the port can accommodate 2000 punctures, it means that equal access to the entire port. So not in and out of the same hole. So basically it's important that you vary the sites of the puncture as well. And like I said, syringes should be sterile and at least 10 ml. The smaller syringes increase the pressure in the catheter wall and it can cause risk of rupture. If you want to use a smaller syringe, they'll have a different hub. The hub is of the diameter of a 10 ml syringe. Only those smaller syringes you can use. Otherwise, use at least 10 ml of bigger syringes. What is other thing that is important is you have to observe septic shower. So this can occur even if on inspection, the site is free from infection. But as soon as you give any, let's say you flush the chemo port and the patient is suddenly going to have shivering or rigors, fever. This is because of flushing of bacteria that is collected in the TIVAD catheter. So it's important that if this is happening continuously, you'll have to probably start antibiotics or decide about removal of the chemo port. And some special access scenarios such as sampling. Blood sample can be withdrawn from a chemo port. There are two methods that have been described. One is a draw and discard method. What you do is you draw up to 3 to 5 ml of blood using a syringe. You discard it because it is going to have the fluid in the catheter. And then you take a newer syringe and you withdraw the required amount of blood for laboratory tests. And then you again have to rinse it. What they say is coagulation profiles need a lot of blood to be withdrawn and discarded because it's going to be contaminated in that area, because especially if you're locking the catheter with heparin. So another method which has been described, which I had not heard about before, was push and pull method or a mixing method. So what you do is you take a 10 ml syringe, you withdraw 4 to 6 ml of blood, and then you flush it back. You do it 4 times. And what they're saying is it's going to be the blood of a peripheral vein sample, basically. So here what you're doing is you're reducing the amount of wasted blood as well. And it's also reducing the hub manipulation because you've just inserted the syringe once. You don't have to change the syringe. So this is one of the methods that you can use. When you're using blood culture, sample for blood culture can be taken using this, but then you do not perform the initial flush to determine patency after accessing the chemo port. And you do not discard the initial sample because that is what has to be sent for blood culture. Coming to high pressure injections, Dilip sir mentioned about using chemo ports for CT scans. So in such situations, you need to make sure that you have a high pressure access port, and you also have to use a high pressure needle. So if you have a high pressure access port, it's very important that you identify the port and the needle. So you have to see the patient records, you have to see the patient identity card or bracelet. You have to palpate the port because you can make out from the triangular shape and those 3 dotted structures that what kind of port it is. So power port is going to have a triangular shape. And also you can take an X-ray to identify if it is a power port or not. So only use CT scan injections when you are sure that the patient is patient has a power port in situ. And smaller needles can cause leakage. The needle should also be securely taped to the catheter again. The catheter length more than 20 centimeter will reduce flow rates. Do not exceed the recommended pressure. And there is some debate that the valve, the Grossong valve, which is present on a catheter, can reduce the flow rate compared to open valved ones. And another important thing is the contrast media should be warmed to 37 degrees Celsius. because if it's not warmed, the viscosity is going to be higher and the flow rate is going to be as much as 50 times lower. And again, you have to rinse with every use. The recommended pressure for continuous infusions, such as if you're using an infusion pump, is 25 psi. And for par injection, the maximum pressure is 300 psi. And these are the recommended needles depending on the flow rates that you need. Also, some people say because it can be positional, the chemo port, if possible, the patient's arms should be vertically above the shoulder with the palms of hands on the face of the gantry when you're doing a infusion of the CT contrast. Now coming to the flushing and locking procedure. Flushing is basically to maintain the catheter patency. Catheter locking is called when you fill a catheter lumen with a solution and allow it to dwell while the catheter is idle. This makes sure that the blood doesn't trickle back into the catheter lumen so that it can avoid thrombosis. At least use 10 ml. And how do you flush a catheter? Orient the bevel of the non-coring needle in the opposite direction, like I had mentioned before. Use pulsatile flushing technique. So instead of injecting 10 ml in one go, keep injecting short boluses of 1 ml solution interrupted by brief pauses. So it says that this will cause a lot of small thrombi to be dislodged. And then also estimated 40% of the initial catheter locking solution was lost due to leakage during installation. So it's also very important that you do it slowly. Another thing that you do is when you are removing the needle after flushing, make sure that it is under positive pressure. What positive pressure means is during a needle withdrawal, you clamp the infusion set when a part of the solution is still left behind. So let's say 0.5 ml to 1 ml. And this makes sure that the needle is disconnected in a positive pressure kind of a situation. The frequency of the situation flushing is variable. Every time you remove a needle, every time a new IV line is connected, there should be flushing. Again, this is not followed by most of the sisters. And maintenance flushes, some people say it should be done every 4 weeks. Some recommend it every 6 weeks. And there are some papers which say that up to 3 months is also enough when the patient is not actively using a chemo port. Coming to the type of solution to be used, this is debatable because some people use just normal saline and some people use heparin. Heparin has its side effects because some people say it can increase the risk of biofilm formation and it also predisposes to heparin-induced thrombocytopenia. And this whole debate of heparin versus no heparin came because of valves, and the Grosson catheter is the most probably common chemo port that you'll use, which will have a Grosson catheter. So BARD says that if you're using Grosson catheters, you do not have to use heparin, and you can use only normal saline to lock the or flush the lumen. But for open-ended ports, heparinized saline is recommended in most of the package inserts. But there have been some randomized controlled trials in Italy and in Leuven which say that there is no difference between using normal saline and heparin with respect to the complications rate. In fact, in the Italy study of 2001, they found that Grosson catheters have higher complication rates because their chances of blockage because of the valve is higher and the flow rate is also lower. But basically, it's non-inferior. Using NS is non-inferior to using heparinized solution. Some people also recommend antimicrobial solution for flushing and especially for locking, especially if the patient already has catheter-induced blood infection. The length, the solution to use and the method of injection and how long to use the antimicrobial solution is all still debatable. There are no guidelines as such on what to do. Coming to blocked catheters, it is possible that you can come across a blocked catheter, especially because of these small blood clots or fibrin sheets or particulate matter which are obstructing the lumen. And in such situations, you can use a fibrinolytic solution instead of redoing the whole procedure. There are various methods to instill these solutions. What is recommended is a 3-way stopcock method or a dual syringe method. This is done very gently. You have to make sure that you repeatedly flush as well as aspirate to to make sure the clot doesn't enter into the blood system and comes out of the syringe. And this can take up to half an hour. You need to give some time also for the fibrinolytic agent to act on the fibrin. So this is going to take a lot of patience, but you can save a blocked catheter if you do this with patients. Various drugs have been recommended. Alteplase can be used, retiplase can be used, recombinant urokinase can be used as a fibrinolytic agent. Arterial catheters do not need, they are not going to get blocked. So you don't have to necessarily check for blood flashback. And you have to rinse with NS and heparinized solution. There's no doubt about it here. For epidural intrathecal catheters, you don't use heparin. For peritoneal catheters, you use a larger volume of syringe. Deaccessing, that is removing the needle from the hub. This is also very important. It has to also be sterile. Make sure that the sister remembers to flush before deaccessing. And and make sure that the reservoir is stable and you pull the needle gently and continuously. And at any point of time, make sure that you never leave open the needle to air, irrespective of it being open or Grosshong, because it can cause air embolism. Coming to the removal of a chemoport, the indication is when it's no longer needed or if a complication develops. There are studies where more than it has been kept in situ for as long as 5 years without any complications. So I don't think there's a set deadline for any chemoport for it to be removed. Infection is the most common reason why you remove it, but removal is only recommended if it is persistent and if it relapses despite antibiotics. The procedure for removal is also similar. You have to make sure that there is strict asepsis. You can do it under local anesthesia. You have to incise the fibrous tissue. Don't excise it because it's going to cause a lot of bleeding. Cut the anchoring sutures. There are two methods of doing it. Some people pull the catheter first and then remove the port. Some people remove the port first and then remove the catheter. So it depends on what you want to use, which method you want to use. Some people suture the tunnel from which the catheter is going passing, so that you make sure that the blood doesn't collect in the pocket. And you have to make sure that you check for the tip to make sure it's intact. Apart from this, it's very important to educate the patient with respect to maintaining chemoport. The patient should maintain basic hygiene, and also it's important to note that the patient can go back to all normal activities once the port site is healed. And there is a Twiddler syndrome, which is mentioned because if the patient keeps scratching the port site, it's possible that the sutures will give away and it can cause inversion of the port. So patient education is how you avoid it. There's a nursing protocol which was developed in Leuven management protocol, which recommended that a dedicated vascular access specialist team should be present for every hospital, which has physicians, technicians, nurses, physician assistants, who have an idea to troubleshoot if you have any issue with respect to chemoports. This is probably going to be very important in the future when a lot of chemoports, when it becomes basically a routine procedure. To conclude, I would like to say that maintenance is necessary, patient education is necessary, and healthcare staff also needs treatment. And it is our responsibility as well to make sure that our sisters are well trained in maintaining a chemoport. Thank you.
Thank you, sir, for that informative session. Are there any questions, anyone?
Thank you so much, Dr. Ganesh, for your wonderful presentation, and you have covered entire things of the maintenance of chemoport. So just
Thank
I
you,
want
sir.
to know, sometimes there is local necrosis of the skin, or there is giveaway of the suture. So in that scenario, what is your advice?
So in a couple of cases where there was no active infection, we had repositioned it in a slightly different position, as in a similar incision, but extended a bit more laterally and closed the pocket to make sure that it's tight, and also make sure that the flap is not very thin, because and some patients we actually even advise to wear a good bra, because that will avoid the stretching of the skin and make sure that it doesn't get too thinned out. So these are probably some of the things that you could do to avoid that.
Would you advise making a new pocket at different place, or you want to close the same pocket?
Sir, I New pocket, I think, will lead to infection, as in would be easier, but then the size of the length of the catheter might become different, and that might displace the tip of the catheter. So if it is possible, if there's no active infection, I think you can resuture it if you have enough, if there's no tension on the skin.
Any other queries from the audience?
Yes, sir, I'd like to ask.
Yeah.
Thank you, Dr. Ganesh, for the wonderful presentation, and thank you for
Thank you.
participating. What is your protocol what is the timing of removal of chemo port in patients of breast cancer?
Breast cancer, we actually remove when there's no evidence of systemic mets or recurrence for at least a couple of years. So there are some guidelines which mention that at least 5 years of disease-free survival is necessary before you remove it. But most of our patients, at least in KGMU, ended up having some of the other complications, or the patient were not happy with it, especially when it's not being used. They consider it a part of their disease because it was inserted when the disease happened. So most of them ask us to remove it slightly earlier, but then up to 5 years, I don't think should be an issue.
Yeah, as a part of our protocol, I think we used to remove it 1 year after completion of the treatment.
Yeah.
And we always used to tell the patient that they have to flush it every month, so that in case it's needed later on, it should be patent.
So that actually is another issue with the patient. Once the patient starts coming for, the patient is under follow-up, we call them once in 3 months, sorry. So what's the point of calling the patient just for flushing the catheter for every month? But then there are some studies which have said that flushing once in 3 months is equivalent to flushing every month. So you could probably take that chance if you want to call the patient once in 3 months.
Thank you so much.
Any other queries?
Yes, just a minor comment. I agree with Dr. Ganesh's observation. We routinely flush it at 3 months, and we did not find any. There were absolutely no incidences of thrombosis or anything. Any of our patients.
Yes, sir. Thank you.
Thank you.
Ganesh actually wonderfully presented, actually very nice. And you emphasize the importance of hand hygiene in chemo when you deal with chemopods. WHO has come out with guidelines saying 5 moments of hand hygiene. And whenever this chemopod, I think in endocrine and breast surgery, there is no place more to emphasize hand hygiene except in this. And when you keep a chemopod for 6 months, the amount of healthcare workers doing hand hygiene is somewhere around 600 to 750 times. It has been calculated abroad. So that much do we use alcohol-based hand rubs to keep the chemopod, and it is also advised that the patients themselves are taught hand hygiene. So these are very important things you emphasized. Thank you so much.
Thank you, sir.
Now we will begin with the most anticipated part of the day, our case-based panel discussion on troubleshooting in TIVAD insertion and removal. Panelists for this session have joined us from all over India. Professor Divya Dahiya ma'am, Professor Pooja Ramakant ma'am, Professor Gyanchand sir, Professor Sabaratnam M sir, Dr. Sanjay Kumar Yadav sir, Dr. Goon Johri ma'am, Dr. Vishwak Chantar sir, Dr. Dilip Hoysal sir. We will take up the cases one by one. To begin with, I would like to introduce Dr. Meghna Shetty from KGMU Lucknow, who will speak on port rotation.
Is my screen visible?
Yes.
Respected panelists and audience, a very good morning. I'm Meghna, Senior Resident, Department of Endocrine Surgery, King George's Medical University, Lucknow. I'll be presenting on port rotation.
We had a 52-year-old lady who was diagnosed with gastritis, clinically T3N1M0, ER/PR negative, HER2 positive, Ki67 of 70%. She received dose-dense neoadjuvant chemotherapy, 4 cycles of adriamycin and cyclophosphamide, followed by 4 cycles of paclitaxel along with 2 cycles of trastuzumab, then underwent right MRM, followed by post-mastectomy radiotherapy. Decision was made to insert chemo port for adjuvant targeted therapy. Chemo port was inserted into left IJV following standard protocol under fluoroscopy guidance. Post-procedure chest X-ray showed the tip to be in SVC. During third cycle of adjuvant trastuzumab, we experienced inability to pierce the port chamber, aspirate blood, and administer chemotherapy. So based on that, we got a chest X-ray done. The picture onto the left of the screen was that of the initial chest X-ray, and onto the right of the screen is that of the chest X-ray done after facing problem in the third cycle. And as seen, the port was flipped. So that prompted us to post her for a reoperation under local anesthesia, and intraoperative we could see a rotated port chamber, the plastic side of the port chamber facing front and the diaphragm facing backwards. It was repositioned, patency checked, fixed to the pectoral fascia with braided sutures, one size larger than the earlier. Totally implantable venous access device play a key role in chemotherapy of breast cancer patients. The advantages of a subcutaneously placed port is that it is invisible, it avoids infection, it avoids social and emotional stigma, and improves quality of life. However, complications remain common in this procedure, and the reported incidence is about 27%. The complications can be divided into early complications and late complications. The early complications occurring within 30 days of insertion, and the common ones are the catheter malposition, extravascular placement, hemothorax, pneumothorax, thoracic duct injury. The late complications occur after 30 days, and the common ones are infection, venous thrombosis, the mechanical complications of the port per se, that includes port chamber rotation or flipping, torsion, catheter twisting, entrapment, kinking, fragmentation, or migration. The mechanical complications limit the port catheter or the chamber use, and the reported incidence of this particular subset of late complication is 4.3%. Amongst which rotation of port chamber or flipping is a very rare complication, and the reported incidence in literature is 0.1 to 0.4%. The term torsion, flipping, or dislodgement regarding port reservoir can be used interchangeably. So what causes port chamber rotation? Use of absorbable sutures for fixation, loose fixation to the pectoral fascia, manual repositioning, thin-built individuals, pediatric population, inadvertent multiple attempts at placing the needle out of the silicone membrane, rectangular design of the port with relatively narrow base, anchoring to the subcutaneous tissue, and excessive ipsilateral arm movements. So there's an entity called as Twiddler's syndrome, that is port inversion is directly attributed to this. So it was first identified and named in 1968 by Bayliss et al. With reference to implantable pacemakers. But it has also been noticed in other implantable devices like chemo ports. So it is unintentional or intentional manipulation of the port beneath the skin, which results in enlargement of the fibrous pocket, and in the longer run results in flipping. So what are the preventive measures that we can take to prevent this, avoid this complication? First is placement of, it has been advised that a port can be placed in subpectoral facial pouch, and creation of a tighter superficial skin pocket for the port placement, use of non-absorbable sutures, and appropriate patient education, as in discouraging frequent touching or manipulation of the port site. The learning points from this case were inability to pierce the diaphragm should make us think about port flipping being a possibility, even though rare. A preliminary chest X-ray will clinch the diagnosis. Port removal is not necessary. Repositioning is sufficient. And it can be prevented by use of non-absorbable larger sutures and good fixation technique. Thank you.
Any questions from the audience?
Any comments from the panelists?
Just I want to comment, like you told about that thin-built patients have more chances of clip rotations. But actually, the patient who are obese and who is inserting is a young doctor and less experienced surgeon. So at that time, they are not approaching up to the pectoralis fascia and not fixing, and they are fixing to the subcutaneous plane. So that may be the one of the cause. So in obese patients, it's also a difficult in which the chances of this rotation is more common.
Yes.
And Meghna, you did well. Just I wanted to add one more point. Bigger pockets may also be. The pocket should be adequate. It should not be too big or too small that we are struggling. So that I think point also helps.
Yes, ma'am.
Yes, ma'am, what I have seen that fixation of the port with non-absorbable suture helps in prevention of this rotation more than a snugly fitting pocket. So many a times what we try to do that we try to make a very like snugly fitting pocket, and at that time we are not able to put the sutures properly, especially when we are in our learning phase. So as everyone tells that pocket should not be big, pocket should not be big. So we try to make very small pocket, and that time we are not able to fix the port properly. So that is more common with that leads to rotation more commonly than you create a appropriate size pocket and fix it with non-absorbable suture. So I have not seen any port rotation till now here. And we try to make pockets slightly bigger and always fix it with non-absorbable suture to pectoral fascia, pectoral muscle. So we have not encountered any port rotation. Thank you.
Good morning, sir. Dilip here. I had one comment to make. When we were residents, we just wanted to finish because the chemoport is taken as the last case in the day. तो बाइट लेके करते रहना, बहुत तीन बाइट भी लेना पड़ेगा फिक्स करने के लिए. So what we I should not be saying this, but we did sometimes try to skip 1 or 2 sutures so that we, अगर छोटा सा pocket है adequately अंदर फंस रहा है अच्छे से, तो पोर्ट खुले कुछ नहीं होगा, बंद कर करके we would do that. So we should not be doing it. We should not take that shortcut. As a resident, I know it is too late in the day when we take these chemo ports, but still we should not take a shortcut by avoiding that 3 sutures. And Abhishek sir would concur with me. Thank you,
Yes,
sir.
Dilip. Dr. Meghna nicely presented. One important thing which I will discuss here is at least in our institute, we get flip ports not only from our own department, but like hematologist placing or intervention radiologist placing. And as Professor Gyan sir rightly pointed out, surgeons will be bold enough to go till the fascia and fix. Whereas a radiologist or a hematologist without and fixing, then it's a subcutaneous tissue is more common. So like if you have somebody in your institute placing chemoports, teach them the thing also, like you will later on they call us actually. So it's better to teach our colleagues also regarding the situation.
Yes.
Next, I would like to introduce.
Gojma, you wanted to add something?
I just wanted to add to everyone else has said. I think getting it right the first time is what all of us are saying. So at the end of the day, most complications and that you discussed, Meghna, and the other speakers will as well. I think it boils down to the surgical technique the first time around you're doing the procedure. So as meticulous as you can be the first time around, that would result in fewer complications in that particular patient. But sometimes everything goes wrong, so it can be a combination of patient factors and surgeon factors and time of the day where you're doing the surgery, like Dilip said. So these are all practical things, but I think for that particular patient and every patient, if you do what you can in your skill set or in your capacity the best at the time, I think that is something to bear in mind. So technique or tissue handling and going in the right plane, fixing. I think if you, as Pooja ma'am said, right pocket size, absorbable or unabsorbable sutures. I think if you've got it in the right place and followed the right technique, I think it minimizes any complication in any procedure. But excellent presentation, Meghna. Thank you.
Thank you, ma'am. Thank you, panelists.
Next, I would like to introduce Dr. Naresh from Rajiv Gandhi Cancer Hospital, Delhi, who will discuss port fracture.
Good morning, everyone. Am I audible, ma'am?
Yes, yes.
And sir. So today I'll be discussing about the one of the rare late mechanical complication of chemoport is the chemoport catheter fracture. Myself, Dr. Naresh from Surgical Oncology DRNP resident in Rajiv Gandhi Cancer Institute. So actually, my head, Dr. Vishwak Chandra sir, he couldn't join us because we had a OT today. So he is operating now. So he couldn't join. So I will be presenting myself. Uh, and thank you very much, ma'am and sir, for today's CME. As I learned a lot of things about the chemoport insertion, the technical aspects, the demonstration of like insertion and the maintenance and removal. So as far as the this particular complication concerned, the incidence reported in the literature is about 0.5 to 1%, and in our institute it's like 0.2 to 0.3%. And the most common site of the fracture being the proximal part between the resources between the port and the catheter, and usually patient presents with the difficulty in flushing the port, and sometimes most of the times the patients are asymptomatic and sometimes can have the embolization of the catheter into the right atrium or ventricles or maybe deep into the pulmonary vessels and can cause life-threatening complications. So regarding our case, she is a 56-year-old post-menopausal lady, BRCA1 mutant. She was diagnosed with the metachronous palatal carcinoma breast. She was already treated. She had been already treated outside for the left breast carcinoma in 2009 and for the recurrent lesion in 2015. And she was on follow-up. So this time in February 24, she came with the right breast lump and on evaluation found to be right breast carcinoma. And we did right MRM in February 24, and the stage was PT2 and 2A. So and triple negative breast cancer. So she needed adjuvant chemotherapy. For that, she underwent venous port insertion through the left subclavian vein, and we usually use the barred port with Grosson catheter, 8 French size. So this is the X-ray immediately after the post-op, and according to one study, Hinks et al., they found the most common cause for the subclavian venous port fracture is the pinch-off syndrome, and they graded as grade 0 is normal, grade 1 is abrupt change in the course. And in our case also, we found this grade 1 pathology, the abrupt change in the course without luminal narrowing, and the grade 2 is luminal narrowing, and grade 3 is complete catheter fracture. So she completed all the cycles adjuvant treatment, and then after 1 year she came back for the follow-up. And during follow-ups, we examined the OPD, we found clinically normal, and we flushed the chemoport as well, and the forward and backflow was present, and we sent the patient for routine checkup like chest X-ray. And this after the chest X-ray, we found that the port catheter has fractured at the same site where we found the grade 1 uh, pinch-off syndrome. So we explained the patient about this particular complication and took the consent for the removal. And meanwhile, we talked to the IR department, and then we shifted the patient to IR department. And uh, the visible part we removed, and for the floating part in the ventricles, the right femoral vein was punctured and catheterized using Seldinger's technique. And if my pointer is visible, we can see this catheter, and this is the snare loop, and this is the floating catheter. Now I'll start the video. So with the help of this snare loop, we grasp the floating catheter like this, and then we pull through the IVC and then through the right femoral vein, and we examined the catheter with the tip, and it was 11 centimeter in length, and there is no thrombus at the tip or tip of the catheter. So in the literature, we could find some possible causes for the fracture of chemoport, that is like high pressure infusion for the de-obstruction of the catheter, and direct catheter injury during insertion by the guide wire or maybe the needle, or pinching of the catheter in the costoclavicular space, that is pinch-off syndrome. And some of the case series have mentioned about the manufacturing defect, that is the high concentration of the barium sulfate is also associated with the fracture. And this is the costoclavicular angle. Like some of the case series and case studies have shown that the more medially we will insert the catheter, the more chances of the crushing the catheter and causing a fracture. So in the below picture, we can see the catheter A, B, and C. The catheter C has most stable, and catheter A has the higher chances of the port fracture. About the diagnosis, the chest X-ray is needed for any difficulty in flushing the port. And some of the studies have mentioned that in grade 2 or more, we have to remove the catheter of the grade 2 or more. If the pinch-off syndrome is showing, then we have to remove the catheter, or grade 1, we can still observe with the chest X-rays needed for the examination. And regarding the treatment, the endovascular catheter removal should be the treatment of choice, and sometimes may need thoracotomy or a hybrid technique by taking help of the 3D imaging and to locate, and then surgery. So the take-home message is the internal jugular vein should be preferred over the subclavian vein, and the lateral part of costoclavicular space should be used as we discussed, and the port catheter should be in the natural axis and position, so that it should be like relaxed. So the junction of the catheter should also be should not bend, and the port should be properly fixed to prevent the rotation. Again, can cause torsion and can weaken the port catheter. And we should always use fluorescence while inserting, and we should look for the pinch-off syndrome. If you are feeling that this patient has the grade 2 or more, then we should immediately remove and reinsert. And the catheter lock mechanism should be designed more soft. And lastly, once the treatment is over, the port should be removed. Thank you very much. Now the session is open for the questions.
Thank you, Dr. Naresh, for your wonderful presentation. So just you told about the fracture. So what is the ideal means? What time it is usually happens? Either it is immediate or it happens during the course of chemotherapy.
So many of the case series does have mentioned that the complications, the port fracture usually occur within 6 months of the insertion. Why? Because they again mentioned the cause, like the costoclavicular angle, the pinch-off syndrome. They mentioned the cause, but some other studies have also shown. Some other studies also shown that the even late also some case series, but most of the case series were focused on the early within 6 months of the port insertion only.
So do you advise that early removal after chemotherapy, you remove this chemoport so it prevents the fracture, or keep it like Dr. Dilip or Dr. Ganesh says that it keep you for 5 years is safe?
So usually what we follow in our institute is up to 2 years we used to follow, and if the patient is disease-free at the end of 2 years of the final treatment, like after the radiation and chemo, we used to remove, sir.
Or what about the material, whether any brand or material for this tubing which is more safer or have more chances of fracture?
Sir, some of the case series have mentioned about the polyurethane catheters have more chances of fracture. And as I also mentioned that most any catheters, they use barium sulfate to become like more radio opaque. They also weakens the catheter strength, and also depending on the angle, the more the medial the catheter is, the more chances of pinch off syndrome and more chances of pinch fracture, port fracture. So if the technique is good and the like material also, we should use more of silicon based the barred port, so we can prevent the port fracture.
Thank you very much. Thank you. And we have Dr. Sabha have lots of experience of managing these cases.
Thank you, sir. It's I don't know whether it's a compliment or but actually we had period where this thing guide wire was left inside during not pinch off 2-3 times, and it was rightly pointed out by Dr. Dilip as well. Like the most youngest surgeon of the team is made to insert the chemo port at the fag end of the day, and like, and there are other factors as well. And you rightly said pinch off, and I have read some literature where pinch off had happened due to swimming by people who have had chemo ports inserted, especially the breaststroke they call in swimming. So there are aggressive movement of that shoulder and the arm is, even though they say you can do everything, but it comes.
Yes, sir. And some studies also found that like we used to insert in the lying down position, so the angle is like adequate, so we don't feel any resistance or something like that. So whenever the patient will sit or something, then the postural changes can cause this pinch off syndrome. So that's why we should go laterally in the costoclavicular space. That's what the case is mentions.
So Dr. Ganesh, as a part of protocol, do you always put chemo ports in subclavian vein, or do you what is the protocol at Rajiv Gandhi?
I think yes, Dr. Naresh.
Can you hear us?
Yes, ma'am. Yes, ma'am. I
Yes,
thought
he
you were
asked.
asking Dr. Ganesh.
Yeah, Dr. Dinesh.
Doctor.
Yeah. Yes, ma'am. Yes, ma'am.
What I'm asking is, what is the protocol at your hospital? Do you usually put subclavian TIVADs, or do you put in internal jugular vein?
Yes, ma'am. We usually prefer subclavian, but if there is any difficulty, then we with the USG guided we insert this internal jugular vein.
So we are joined by Professor Gaurav Agarwal sir also, and I think he is the one who has taught us, most of us in fact, the procedure of chemo port insertion and everything regarding that. So sir, any your comments on the current case or the last case? Sir, are you there?
Yes, I am here. I'm sorry I was not paying much attention, so please forgive me. But I did hear about the flipping of the port and then the pinch-off syndrome. Yes, over a period of time, we all get to see these complications and problems. Don't know what to say about this particular case, but generally be prepared both during the process of implantation and as Dilip said, I mean, this was a revelation that you all have been cutting corners. I get to know now some of the reasons of why our patients have problems. Anyhow, don't cut corners and fix the ports well. And I think one important point that our friend Dr. Kharwal mentioned, and this is something I've been pointing out again and again, try to make or try to keep the angle of catheter as obtuse as possible and as less acute as possible. And that will be possible when you insert or you do the cannulation of the IJV as low in the neck as possible and plan the port, the pocket as laterally as possible in the deltopectoral. on top of the second rib or maybe third rib, so that you enter the vein as low in the neck. And if you're doing subclavian puncture, like was pointed out by Dr. Kharwal, then you enter it as lateral as possible. And that will help us prevent the pinch off. The problem with subclavian entry are two. Number one, it is a little more problematic. It can lead to pneumothorax, though fortunately very rarely. And the pinch off is commoner with this, and that is why we have primarily been using IJV cannulation and not subclavian cannulation. But I think I have seen sufficient number of complications, and we'll continue to manage more and more in times to come. More you do, more you recognize. We have had patients with fractured catheters needing endovascular retrievals in the cardiac cath lab. I remember 2 such patients. We have had flipped ports, which is not so uncommon. And for many of these flipped ports, if the pocket is quite not very loose, you can try to manipulate them to unflip them and leave them anchored with a needle for some time. Strap them on the surface. It is possible that you may be able to avoid operating to fix the ports again. So this may be just a temporary flip. You can manipulate them to unflip them, flip them. But I think what maybe you've already discussed while I was not connected, the commonest problem is blocked ports, where the catheter is not functioning. You have to unblock it. And I'm sure many of you have seen all the maneuvers you can do to try and unblock them. Even more commoner is no backflow. You are able to use it for infusion, but the catheter there may be a film blocking the backflow, and so you're not able to withdraw blood. But that's acceptable. But if so long as you're sure that the catheter is inside the vein, it is patent, you're not causing extravasation while I'm listening to some part of the discussion and learning. Please go ahead. Thank you very much.
Next.
Now I would like to invite Dr. Sabaratnam sir to present his case.
Actually, thank you, Dr. Sara, Dr. Abhishek, and Professor Mishra sir for this invite. And on Saturdays, we have what is called clinical teaching grand rounds. So our younger generation endocrine surgeons, when they're busy with the grand rounds, I thought I myself will present this case. So, and I'm sorry I have not made it formally. It's a very informal 3 to 4 minute discussion. So I thought the catheter touched the heart, but it touched the brain, unfortunately. So now to go to the next slide, please. And thank you, Sara. Actually, Dilip shared very nice photographs, memories. But being evidence-based, I put her logbook, which shows 129 pages and a lot of good memories for her there in SGPJ, almost all awards possible. Thank you so much. And coming to this patient was a 75-year-old lady, actually luminal layer breast cancer, underwent breast conservation surgery, and she was very happy with this after surgery. So once patients are happy, she thought she will go for a chemopod placement. We did do the placement on the right side, and you can see the catheter going in the reverse direction, and the position of the chemopod was confirmed after insertion, and there was a good backflow. It went above, actually. So when I came for morning rounds, this was the picture we saw, actually. And chemo, this removal is usually done under local anesthesia. Then I had to discuss this with the patient. Patient was fine, actually, and we did remove we did remove the chemo port. So port which was there, proper placed, and then next day what might have been the reasons. So initial malposition at the time, which is not there in this patient, but I will discuss. So guide wire misplacement can make this thing happen. Forceful catheter advancement. Do not forcefully advance a catheter. I have one another very interesting thing where the guide wire got curled around the subclavian artery, and she was about to undergo a sternotomy to remove. Fortunately, we removed it, and that was published in BMJ anesthesia actually. And there is if there is inadequate catheter length, too short, then it may drift retrogradely. Go to the next slide, please. And this might be the thing in this patient. Post-operatively, excessive neck movements like flexion, sudden jerky movements. If you are not fixed the catheter properly, and increased venous pressure, and especially in old patients with hypertension. Go to the next. Hypertension can also cause. I am coming to that in a while. So flushing related issues. Sometimes if there is resistance, do not flush very aggressively. That can also cause catheter migration. Go to the next one. So reversal of venous flow in IJV. This is common when you have heart failure, fluid overload. So sometimes if these ports are inserted in conjugation with other coexisting surgical procedures, and if you give too much fluid in a already failing heart, then there have been reports where the catheter migrated. So the management includes, we have to confirm the diagnosis. Then the other thing is, once you confirm, there are two things. One is easiest thing is to remove, but that is, if this patient was elderly and we were a little worried, and if it is a young patient who wants the port in situ, reposition it using a guide wire, and catheter exchange over a guide wire if reposition fails. Thank you.
Thank you, Dr. Sabha, for wonderful presentation. Just I want to know at what time you find this catheter migration, whether it was in the check X-ray immediately after inserting the port, or it was after few months or few chemotherapy.
No, sir. Actually, we inserted the chemo port at 8 p.m. in the night. So that time the port was in the place where it should be. And night 10 o'clock X-ray test was done. Morning during rounds we found this. Like actually, we have a system where the X-ray is collected in the morning actually. So this was the thing.
Anybody else wants to add anything?
Sir, for that case, I would like to comment. If I remember right, sir, it is, I think, me and Madhu who were there, and I was the senior guiding Madhu. And I was very sure because she showed me the C-arm, she showed me the X-ray, the port going down. But when we got the X-ray, when I saw it, me and Madhu were completely in, I don't know, shock. कि ऐसा कैसे हो सकता है? So we did not have an answer for Sabha sir's question कि ये कैसे हुआ? So we said sir C-arm का भी photo है, and I showed him the photo कि sir last photo ये है C-arm का, आप देखो. And I don't know. It is something which is even till date, it is still troubling me in my mind, and that is one case I still remember after 3 years. So
Dilip, thank you so much. Actually, that you showed me the CM photos, and we were all worried how it migrated up. Now going back and then reading, and when they asked for this, we had many interesting cases. But in this, I thought something will come out with discussion. And as you rightly said, the patient is still very happy. She comes to regular follow-up, and she was so impressed with the care of us that she even donated 2 wheelchairs to our department, actually. So, as you rightly pointed out, the team, 3 of us, did discuss what is the best management policy for this patient, and because everything was right about the insertion part. but some things that makes medicine interesting, is it not?
True, sir.
So Sabha, thanks for sharing this interesting scenario, and we all will remember it. So we learn from our own complications. So I think one thing you also highlighted, I think we need to realize we should not do chemo port insertions in the evenings. Once we are all tired, I think we should do with a fresh mind.
Yes, ma'am. Actually, we are getting a third OR. Actually, we will do chemo ports in the morning. Actually, now a recent concept. Yesterday, I was seeing a patient referred by our endocrinologist. They are given midnight thyronome. So like that, thyronome can be taken in midnight, and chemo ports can be placed in the morning.
Gaurav sir has
I'm wondering, ये दिलीप को क्या हुआ? Has he injected some truth serum today, or is it Mumbai air which is doing some good to him?
No, I remember these cases. These cases have taught me कि क्या नहीं करना है. मतलब तुम कितना भी कर लो, there is one port which is gonna tell you that you are no bigger than me. I hope everyone who has done many ports would agree to this fact. I was just sharing my experience.
Right. Good. But as Sabha said, we've been trying to somehow make arrangements to do these cases in the morning or during the working hours and not late in the evening. But I remember the first few chemo ports that we implanted used to be in the DSA room in radiology. For good 5-6 years, all those chemo ports were implanted in radiology department. I'll take help from Dr. S.S. Bajal or Dr. Manoj Kathuria. These are ex-faculty in radiology who would help us with that. Because we did not have CM, we did not have ultrasound either. For many years, we would do IJV punctures without ultrasound guidance. But fortunately, now we have those things. Hopefully, as Sabha pointed out, in near future, we will be not waiting for 7 p.m. for posting the chemo ports.
And Gaurav sir, I feel कि इतना efforts हुए हैं, Sarah has put so much efforts in organizing CME. We should publish it together, all what has happened today. So I think that will be a good outcome of the CME.
Yes, ma'am, I totally agree.
Why not? Yeah, you can compile all the complications, especially jokes apart, complications are the most educative part of any discussion. So you can compile all the complications, how they were detected, how they were managed to make it fruitful. Okay, thank
Dr.
you.
Pooja, I have a suggestion, like all these things what you are saying, we can publish. We have the journal issue is coming from Indian Endocrine Surgeons Association. So in that journal, we can have this brief description of all the cases and the complications.
Yes, sure. Divya ma'am, we should publish in that. Yeah, Sarah may coordinate and follow it up because right now everybody is fresh, so everybody will be happy to write in the next week or so, 2 weeks.
Yes, ma'am, definitely. I'll work on it, ma'am.
Next, I would like to introduce Dr. Asya Zehra from KGMU Lucknow, who will speak on port extravasation.
Is she on me?
Yes, she's on.
Good afternoon. Is my screen visible?
Yes. Make it full screen. Yes.
Good afternoon. I'll be presenting chemotherapy extravasation from Chemoport. I'm presenting a case of a 58-year-old lady diagnosed with carcinoma left breast. Her performance status is ECOG 1 and she is resident of Nainital, Uttarakhand. She presented to us with lump in her left breast for 1 year with no history of nipple discharge or pain, no history suggestive of metastatic symptoms. She's a postmenopausal lady and was was evaluated at a hospital in Mumbai. She was diagnosed with left carcinoma breast, T2 multicentric disease, N1 M0. Postnatal biopsy was IDC grade 2, ERPR positive, and HER2 negative. Her PET CT was non-metastatic, so she underwent left MRM with chemoport insertion on 22nd of April 2024. And during chemoport insertion, right IJV was cannulated and CM confirmation done. This was all done at the private hospital in Mumbai, and she then presented to us to the radiation oncology department and was planned for adjuvant chemotherapy and radiotherapy. She was given pre-chemotherapy drugs and cyclophosphamide from the chemoport, and during adriamycin infusion, she developed swelling, redness, erythema, and tenderness around the chemoport site. The infusion via chemoport was stopped and it was given through peripheral line. The patient was then referred to us. On examination, her vitals were stable. She had swelling, erythema, elevated temperature, and tenderness around the chemoport site. There was no sign of fever or tachycardia, and on attempting aspiration, no backflow was noted. On ultrasonography, hypoechoic collection was present around the chemoport and it was aspirated. Cannula was secured into the chemoport and backflow was obtained, and chemoport was then flushed with 5 ml of heparinized solution. She was advised cold compresses, analgesia, and antibiotics and was referred back. On follow-up, on 5th day, her erythema, pain, and swelling had decreased, and on 14th day, her symptoms had resolved. She then further received chemotherapy via chemoport uneventfully. So it was a grade 2 extravasation, and her cause of extravasation was dislodged needle from chemoport. This is a study published last year of 119 patients done at RML Lucknow, and they reported complications of infection of being 7.5%, followed by drug extravasation 5%, and rest thrombosis, wound dehiscence, and necrosis. Drug extravasation 5% cases, 83% cases were managed conservatively, while 17% required chemoport removal. The ESMO guidelines describe the management of chemotherapy extravasation. Incidence of chemotherapy extravasation that has been described as 0.01 to 7%. So this step 1, when chemotherapy is extravasated, first step is to stop the infusion. Second step, identify extravasated agent, and TIVAD is to be left in place, and extravasated agent has to be aspirated from the cannula. Then non-specific measures like analgesia, fluid therapy, antibiotics have to be started. Specific measures have then to be sought. If anthracycline is extravasated, early administration of dexaron is started. Then identify the extravasated area. Chemotherapy drug has extravasated into pleura, urgent thoracocentesis and thoracic tube drainage is done. If mediastinum, then thoracotomy or thoracoscopy guided drainage is done. And if subcutaneous tissue, then conservative management, as in our case, or consider surgical drainage. Non-supportive measures like fluid therapy, analgesia, antibiotic, and oxygen therapy have to be continued if required, and patient has to be seen for resolution. If progressive resolution, outpatient management is done. If there is no resolution, then other surgical procedures and workup has to be done. Chemoport should be removed if required. So learning points from this case is that medical team dealing with chemotherapy should be adequately trained. Patient should be aware about the possibility of needle displacement and symptoms associated with chemotherapy extravasation. Correct needle placement, discontinuing infusion immediately, using of ice packs, decrease the spread of drug and surrounding tissues, and early recognition with major complications. Thank you.
Anyone wanting to add anything?
Thank you, Dr. Asia. Very nice presentation. Like, how many percentage of your patients get chemo through peripheral lines? And like, is it, do you encounter peripheral line extravasation as well?
Yes, so we encounter peripheral line extravasation as well. Majority of our patients get chemotherapy via the peripheral line.
Okay. Because actually that's a like a chemoport extravasation is rare. Very nicely you discussed. But peripheral line also we should tell, we should instruct our nursing officers, like that is very important part actually. And wide bore needle, not a very small, and relatively bigger vein would be a better option.
Yes, sir.
Yes, Sabha, you well said. Even, in fact, the peripheral extravasation is more difficult to handle. That doesn't heal well, and patients get very ulcers. I've seen patients for months, the ulcers have not healed, and you can see the muscle and the tendons. It looks so bad. This patient, the problem was it was handled by department who are not regularly giving chemotherapy through chemo ports. That was a problem. And this lady was operated in TMS and then referred here for the medical part. So that was how problem happened, and then we were contacted. Luckily, she was managed with conservative management, but she had a lot of anxiety about removal, and then she gets a chemo port in Mumbai and comes back, and we are removing it. So that was very bad. So we try to manage her conservatively.
I just wanted to add a couple of things, ma'am. So therapeutic agents are basically divided into vesicants and non-vesicants. That is one which is irritant and non-irritant. So among whatever we give in as a breast chemotherapy, most of them are irritants. Then again, what we generally give is anthracyclines and taxanes. So for anthracyclines, it's the protocol is to localize and neutralize, and for the taxanes, it's to disperse. So in one case, we need to apply warm compresses, cold compresses, and the other case we need to apply warm compresses. So, and ma'am, I wanted to ask if you used anything to neutralize, like Dexa, Roxazine, or DMSO, anything in this case?
Yeah, Dexa we gave, but we didn't injected it, I think. We just gave her the tablet forms.
Not around the extravasation site? No.
No, not around there. We gave her antibiotics, analgesics, steroids, just for letting it, and the chemotherapeutic agent was aspirated also.
Okay.
So she was better in a week's time. We thought in a week's time, if she worsens, we'll remove it. But if she settles with antibiotics and all these things, we will try to preserve it. So that way she settled.
Okay. Okay. Next.
So thank you, Asia. She's our wounded warrior. She met with an accident 3 days back, had a fractured rib, but still she managed to present here, and that too from the OPD. So that's how our life is. Even if we are injured, we still come to work, and the work goes on.
Thank you for presenting, Asia, and hope you get well soon.
I would now like to introduce Dr. Devam Baderia from NSBMC Jabalpur to present on port infection.
Good afternoon, everyone. Good afternoon, everyone.
Good afternoon, sir. You can share your screen, sir. Name?
Has he
joined? Yes.
Yeah.
Yes.
Good afternoon, everyone. Today I will be presenting
Yes, sir. Please go ahead.
infected but indispensable case of TIVAD to remove or not to remove.
Subject. Please make your screen.
Slide share.
Right. 5.
My screen is visible.
Yeah, screen is visible, but it is not in a full screen mode. Please press F5 in your keyboard.
I've done that.
No, sir, not yet.
We have his slides, we can share it. I think we have his slides. Dr. Devam, is it fine if we share your slides from here?
Yes, ma'am. It's fine, ma'am.
Second last time.
Yes, sir, please start.
Good afternoon, everyone. Today I would be presenting a case of TIVAD, infected but indispensable. Should we remove it or not? My patient is a 25-year-old. Next slide, please. My patient is a 25-year-old female. She is a known case of carcinoma right breast and on treatment since 2022. And in 2025, she is diagnosed as a case of CA left breast. She is planned for chemotherapy. She underwent TIVAD implantation in February 2025. Then, after a week, she presented with a local edema with purulent discharge over the TIVAD site, and she was having a low-grade fever associated with that. And this was the clinical state of the patient. Next slide. Then, what should be our next step for this patient? Then we went for the blood culture. The blood culture came out positive as Staphylococcus epidermidis. The clinical dilemma was that should we remove the port, or should we salvage it, or should we remove it? The port infections can be local or systemic. Next slide, please. The local infections present with erythema, tenderness, and purulent discharge at the catheter insertion site. And systemic infections present with positive blood cultures, fever, chills, and hemodynamic changes like instability in blood pressure or heart rates. Next slide, please. The infection can be tunnel exit site infection or catheter-related bloodstream infection. The tunnel site or exit site infection is inflammation or infection along the catheter external part or exit site. And CRBSI, the catheter-related bloodstream infection, are the infection originating from the catheter. Like for the diagnosis of these patients, we usually do ultrasound or CT scan, which are useful in detecting the abscess or thrombosis near or at the catheter site. Now, the biggest thing is when should we salvage the catheter and when should we remove the catheter? The decision making for these are we should salvage the catheter when the patient's hemodynamic is stable. There is no sign of tunnel or exit site infection, and the infections are caused by low virulence organism like Coagulus secretus staphylococcus. And we should remove the catheter when there's persistent bacteremia, like ongoing bloodstream infection, presence of a port pocket abscess, infection with high virulence organism like Staphylococcus aureus or any fungi infection. Now, what is the role of antibiotics and lock therapy in these patients? This treatment of systemic, the last technique, the systemic antibiotics. The systemic antibiotics are administered on the base of culture sensitivity result. Then antibiotic lock therapy, that is the ALT. This is the installation of high concentration of antibiotic in the port. The dwell time for these antibiotics is 12 to 24 hours, and these are used in combination with systemic therapy for to salvage the ports. If we have removed the port, when it is safe to reinsert these ports. Next slide, please. The first thing is port infection management, microbiological resolution of the infection. That is typically 48 to 72 hours afebrile period with no fever. We should ensure that the patient has negative blood cultures before reinsertion. Reinsertion consideration should same site reinsertion. Avoid if the previous site had. We should avoid same site reinsertion if the patient has previous site had tunnel infection or abscess. Contralateral site reinsertion is preferred if the catheter was removed due to infection. Timing, it is balance between urgent chemotherapy needs and the infection control. We had salvaged the patient catheter and we have given her the antibiotics, systemic antibiotics, and this was the After 1 week period, this was a catheter clinical picture of the catheter. Next slide. The take-home message from for the infection is we should distinguish between the local and systemic infection. Early identification is crucial for appropriate management, and we can salvage the port. Salvage if a feasibility with low virulence organism and the patient is hemodynamically stable. We should administer antibiotic lock therapy. It can avoid catheter removal when used appropriately, and safe in research requires careful timing and site selection for optimal outcomes. Thank you, everyone.
The floor is now open for any questions or thoughts anybody would want to add.
Thank you so much for your nice presentation. So you told about the infection of virulent and less virulent, and you can preserve the chemo port in the less virulent. But in sometimes what happens, because this is for the chemotherapy and patient receiving the chemotherapy get infected the chemo port, and they develop some unusual bacteria which is low virulent, but they are present and they are resistant to most of the antibiotics. So in that case also you have to think about whether you have to reserve the chemo port or you have to remove it. So what is your thought on that?
So if we don't have antibiotics for that organism, it can be a problem for that. We should remove the ports in these patients.
Okay. So you remove in all these patients when there is an unusual type of bacterial infection is there.
Did you use the antibiotic lock therapy in this patient?
Yes, sir.
Okay, so that worked, right?
Yes, sir.
And so that is the reason you were able to preserve the port.
Yes, sir.
Okay. So what antibiotic did you use?
So we went for the blood antibiotic resistivity also. So we had used for this patient.
Yes. Are you there?
Yes, yes, yes.
Okay.
Yeah, Abhishek, he might not be knowing because he was not involved with the care of this patient. Yeah.
What antibiotic did you use, sir?
We used piperacillin tazobactam.
And it was inserted in the port and kept in it for around how much time? Just single shot or multiple shots?
Only single shot.
Single shot.
Yeah.
Thank you.
Are there any other comorbidities, Sanjay, besides cancer and chemotherapy? It's a fairly young patient. So how many days after insertion did this happen?
Yeah, so as you said, she is very young patient. She did not have any comorbidities, except for that she received chemotherapy for the earlier breast cancer.
Which was many years ago, wasn't it?
Yeah, yeah. So apart from that, she did not have any other comorbidity, and she developed port site infection within after 4 to 5 days, I think.
Maybe a component of asepsis at the time of insertion or therapy.
Yeah, could be, yes.
Thank you.
Next, Dr. Satyajit from PGI Chandigarh will discuss arrhythmias and seizures post TIVAD insertion.
Good afternoon, everyone. Am I audible, ma'am?
Yes.
So today I'll be discussing a case on troubleshooting in TIVADs insertion, arrhythmia and seizure. So my case is a 26 years lady She had a history of periampullary carcinoma and underwent Whipple's on 13th of November 2024, and then she was planned for adjuvant chemotherapy. She received 1 cycle of FOLFIRINOX and had extravasation from her veins, was planned for chemoport insertion on day-care basis in our department. So initially she was put on the OT table. ECG leads and monitors were attached. Baseline vitals were stable, and she was in the supine position with neck extended, and under ultrasound guidance, IJV was delineated and local anesthesia was given, and then IJV puncture was done. After that, the guide wire was placed, but immediately after placement of guide wire, the patient developed atrial fibrillation. So the ECG monitoring that revealed the onset of atrial fibrillation with rapid ventricular response, and the heart rate was till 160 beats per minute. So immediately we withdrew the guide wire, and then oxygen supplementation was done. And so immediately the anesthesia team came for support. So IV metoprolol was administered for rate control, but the rate was not controlled. So amiodaral infusion was started. So after that, initially the atrial fibrillation settled, but after 15 minutes after that, she developed generalized tonic-clonic seizure activity, lasting for approximately 2 minutes. So she underwent a airway protection was done initially, and oxygenation by bag and mask ventilation, and IV lorazepam was administered to terminate the seizure activity. So she developed again. So initially the seizure activity was settled. After that, she received another repeat seizure episode was done there 15 minutes. So it was lasting for 3 minutes duration. And again, IV lorazepam was repeated and loading dose of phenytoin was given. And blood gas analysis showed metabolic acidosis with hypokalemia. So potassium correction was given. And again, repeated seizure episode was there. So sedation was started with propofol and midazolam infusion, and a GCS also dropped. So it was GCS of 8. So patient was decision was made to intubate the patient, and she was shifted to ICU. But sedation could not be weaned off as patient developed focal seizures, and neurology consultation was taken, and injection levetiracetam was started. And CT angio was cerebral vessels and venogram was done, which showed right frontal subcortical hypodensity, and the neck vessels are normal. There was a contrast-enhanced MRI and EEG was done, which was suggestive of diffuse hypoxic brain injury with left hemispheric structural and functional dysfunction. So she was managed conservatively with anti-epileptics and supportive care. Total parenteral nutrition was started, and she was extubated in day 10. And after that, she underwent partial neurological recovery was there after 2 weeks, and patient got discharged in stable condition, tolerating well orally, but left-sided hemiplegia was persisting. So the possible etiology and contributing factors can be direct irritation. So the catheter was placed too deep in the right atrium or right ventricle, can mechanically irritate the heart's conducting system, and it can also trigger ectopic beats leading to atrial or ventricular ectopy. And also increased risk of atrial fibrillation can be because of repeated stimulation of atrial tissue leading to atrial fibrillation or flutter. And atrial fibrillation induced cerebral hypoperfusion can be there. So a thromboembolic event leading to transient ischemic attack or stroke can be there. And contributing factor can be the long fasting and the resultant hypokalemia of the patient. So coming to this discussion, so incidence of arrhythmia after central venous access, it is transient arrhythmias can be seen in 20 to up to 20 to 30% of the cases. And so limiting the depth of guide wire insertion to less than 16 centimeter avoids this complication, and ultrasound along with fluoroscopy can help in guiding the catheter to its final position and confirming the tip placement. So the lessons learned at the multidisciplinary team approach is required with a experienced surgeon operating to oversee the procedure, and continuous monitoring is required, and anesthesia support is also required, and fluoroscopy can help in better outcome and avoid long fasting hours and correct the electrolyte disturbances, and anticoagulation can also be given. So to prevent the further complications. That's all.
Thank you so much, Dr. Satyajit, for your excellent presentation. And just one thing I want to add or give a comment on that. For the using of local anesthesia, if you are using the concentrated local anesthesia and injecting directly into the vein accidentally, then also this situation may happen. Arrhythmia and convulsions happen. So that's why you have to be careful while using the local anesthesia and use a diluted local anesthetics and try to aspirate before injecting the anesthetics agents into the surrounding structure.
Yes, sir. We diluted the local local anesthesia to 1:2. It was 10 ml of lignocaine was taken along with 40 ml of saline, and then it was injected around the. Once we aspirated the before injecting, and means we started the procedure 20 minutes after the local anesthesia was injected.
So when this conversion happens at the time of local anesthesia or at the time of catheter insertion?
Yes, sir.
What was the timing in your patient? This arrhythmia, when it happens?
The time after local anesthesia, the timing.
No, sir is asking when did the arrhythmia happen? After what timing? After local
So
anesthesia?
it occurred after guide insertion. So immediately after the guide is inserted, the patient started developing arrhythmia immediately 1 minute after guide insertion.
How deep was the guide wire inserted? Means the entire length or
No,
some
not
part?
the entire length. Some part was left outside, but we didn't do it under fluoroscopy guidance. So means
So you couldn't know where it was exactly.
Yes, sir. Maybe the possible etiology is that it has touched the right atrium and that led to the eventual complications.
Yeah, maybe, but most of the time what we do, we also put the entire guide wire, but most of the time it's almost through. But fortunately or unfortunately, we have never encountered this issue because even the catheter, when we put, sometimes it goes in, it almost lies in the ventricle or atrium. So also there might be some predisposing factors, as you already mentioned. So
Yes,
that
sir.
might contribute to the arrhythmia. Yeah.
Yes, sir.
Okay, nice case. Thank you.
Yes. Thank you.
Any other comments from us? Any panelists?
Was there any previous history or suspicion of epilepsy or any other, or was this the only plausible explanation for the seizure?
No previous any seizure was there. So this was the first incident that occurred.
And did she make a recovery from the diffuse hypoxic brain injury? That sounded really scary. As far as I'm aware, I don't think you completely recover from that. Did she have any permanent cognitive damage besides the hemiplegia?
Her GCS improved to 15 out of 15, but there was a left-sided hemiplegia was persisting still. It's still persisting in the post-op period now also, even after 3 months.
Quite drastic after this procedure, but thank you for sharing.
Yes.
Last but not the least, we have Dr. Dilip Hoysal sir, who will discuss injury to carotid artery during TIVAD insertion.
I'll do the port migration first and then come to the last and the important one.
Sure.
Yeah. So coming to the TIVAD complications, one which we have encountered is in a 46 premenopausal lady underwent who is a right breast cancer 88 negative, underwent chemoport insertion elsewhere, and she came for only chemotherapy with us in the hospital, and from the catheter clinic she was referred to us saying that we are not able to locate the chemoport. So what we did an X-ray. saw the X-ray is somewhere lying down here in the breast. So first instance, we did an X-ray, found out it is somewhere else. So that had to come out. So the next thing is we did another X-ray, it is in another place. So took it out through the same incision through the scar. So why do we need to know where exactly is the catheter and why we should be able to palpate it? The reason is the thing is that we had to remove it and put a arm port inserted for her. So what is an arm port? Arm port is where you insert it through the medial aspect of the arm and the entire catheter is going to come and sit at the right bronchus. So this is an arm port which has been put here under interventional radiology guidance. So why do we have to know that? Why we have to fix the chemo port is because of this. If we don't fix it, it is going to wander in the entire breast. Breast is such a mobile organ, it can go anywhere in the breast if it is able to make its own planes. Now, until and unless you are very, very sure that you are the chemo port is in place, do not inject any drug. Otherwise, we are going to end up like this, having a drug extravasation. Neither we can excise it nor we can remove it. Now, if I put an incision, it is not going to heal because she's already started on chemotherapy. And it is a tough task for us to manage such a case. Now, if you can see, this chemo port puncture was done on the left side, and the vena puncture was done on the right side, and the port was inserted on the right side. So this was the learning point from this X-ray. The chemo ports can migrate within the breast if you have not fixed them properly. So this was the first case. Coming to the second case, any questions on this case?
We take them together. You please go on with the next case.
Yeah, please. Yeah. Yes, sir. Yes, sir. Yes, sir. So this is the next X-ray. Yeah. So in another case, we had a venous access device in an artery. Which is this artery? It is the carotid artery. So 61 postmenopausal lady, early breast cancer, 882 plus CQ fish is amplified, underwent right VCS and right chemo port insertion on 27/9/2024. Now, chest X-ray done, immediate post-op showed this. So I got a call at around 8 o'clock, sir, कि ऐसा है तो कहाँ है chemo port बताओ sir करके. So the entire team, we all of us sat, discussed, had a informing call. We said, okay, fine. I felt that it was already in the carotid, so I told her probably it is in the carotid. So my chief Shalaka madam said, sir, at least let's get a CT done, CT angio done. So we got a CT angio done. We saw that the chemo port is in the carotid. We did a CT angio. It is the carotid entry, the chemo port entering the carotid. So it showed a partial filling defect seen in right proximal common carotid artery at its junction with the subclavian artery and the brachiocephalic. It is an undefined hypoechoic collection also noted. There is some hematoma if you can see around here. There is a hematoma there. So in the upper part of the chest. So I said it is already in the carotid. We should go ahead and take it out. Believing it might lead to delay and she might end up having a thromboembolic episodes. So I pushed for it. I pushed for the saying that we will take it up, and I've done quite a bit of chemo ports and let's do it under local. So I took it up under local at 2 a.m. But I did keep the anesthetist on standby, which was lucky for me, and I was little humbled to have done that, to keep them on standby, made sure that the patient was NBM before I took her at around 2 o'clock in the midnight. So we removed it under local, gave compression, but patient developed rapid neck hematoma in spite of good compression. Was unable, I told the anesthetist, please tube the patient. She was unable to intubate the patient. Saturation went down to 77. I realized that it is a rapid neck hematoma. So the endocrine surgery did help me a lot here. I put an incision like a thyroid, just placed the incision, drained the neck hematoma. Immediately we were able to see the cords and intubated the patient. All of this happened within 3 to 4 minutes, so that there was no hypoxic injury to the brain. So there was a rent when I opened. Once we tubed the patient, I explored the entire area, drained the entire hematoma, placed a proline 50 stitch on the common carotid where there was a rent, and shifted the patient, intubated to the ICU. We got a Doppler done, made sure that there is no thrombus or carotid dissection. and then extubated the patient. Patient was discharged on post-operative day 2 and she was uneventful in the post-operative period. Now presently she is receiving chemotherapy. So went back, saw that up to 40% of carotid punches are associated with uncontrolled bleeding or hematoma. And this was one of them, which really gave me a nightmare on that particular night. So what are the learning points? So look for automatic filling of the syringe as soon as you put, if it is in the carotid, take it out. So look for this spurt when you remove the dilator. See if the sheath is, if the blood coming out to that sheath is a spurter. So then please remove your catheter, you remove your dilator and the sheath out and give a good compression for 10 minutes. Catheter should always be to the right of the trachea unless the patient has a situs inversus or any other congenital abnormality. So what to do if you do a carotid puncture? Really good compression for 10 minutes, keep superiors informed, be prepared for a neck exploration whenever it is required, which is quite a rarity, but still it is really needed. The skill is needed to identify that there's an expanding hematoma and you need to place the incision. And always, always, always connect an IV line and a saturation probe monitor to monitor the vitals whenever you are doing it under local anesthesia. It should be a norm should that you're doing all these things under whenever you're doing under local anesthesia. If things go bad, call for help, secure the airway and control the bleeding, inform the IR team. They might be of help in any manner. So I am happy to take questions. Any questions?
Dilip, that sounded like an episode from Khatro Ke Khiladi.
Yeah, it was, ma'am. It was, ma'am. I was like कि मैंने क्यों लिया रात के 2 बजे इसको.
Yeah, that is literally my first question. Was it just logistics or
No,
that could it have
I
been
did
planned
go
better?
through, yeah, before I took her up at 2 o'clock, I did go through the literature, thinking matlab arterial catheters, how much they have a complication. And I could see they had about 30 to 40% complication of having a thromboembolic episode. And now she has it in the carotid, and I was really scared that she should not end up having a neurological problem. So that was the only thing which drove me to take her up immediately. If it was in a periphery, I would have waited till the morning where I couldn't get a plastic team or a recon vascular team to help me out if at all if there is any major injury. But I was quite confident with my even vascular skills that I could still try and suture up an artery there. But yeah, carotid is something which we need to be extremely careful.
Yeah,
So
I think
I just did back my skills. That was the instinct. I think probably I was wrong and I was lucky.
yeah. I mean, yeah, it worked. I think it all's well that ends well. So
yeah,
as long as you got away with it safely and patient is fine, it's
yeah,
okay. But there are lots of learning points in this case. It was right from the
very,
beginning. And I mean, I'm
yeah.
surprised the catheter went that far and patient came out, had the chemo port and had the X-ray. Usually you'd pick it up at
On
the
table.
first puncture or when you put the guide via the catheter, as you said. I mean, it has happened. We've all seen it.
Yeah,
But all it takes is just recognizing it there and then. So somebody was really thorough when they were doing it, and then they managed to cannulate the carotid that far. Yeah, but I still think I mean, it's good you came out safely from it and you've got your good set of skills, but I think from the learning point of view, it's not something we would tell, say, a junior or a trainee that
No,
it's
no, no. I
something
would
that they
definitely.
should
So
attempt.
I
So
landed up in the theater because
yeah,
of the same fact.
so
If I had told my resident to take it out, then that would
yeah.
have gone really bad.
Yeah, it's a good thing you prepared for anesthesia and things, but then yes, it was brave of you to take it up under local and do it at 2 o'clock. But yeah, well done in the end, I guess.
Lots of learning from this case.
Yeah. Yeah. The first case that you presented, the two X-rays that you showed for migration of the chemo port, were they literally taken fairly quickly? Like how far apart were
No,
they?
I think one came to us when she came to the OPD, we got it done. Usually catheter clinic, whenever they're not able or they're not getting a backflow, they do a X-ray. So they, as a protocol, they do an X-ray from the catheter clinic, and they, with the X-ray, they send it to us. So I saw that and I said, okay, this needs to come out. And in the meantime, medical oncologist thought, why not get in another chemo port inside in the same setting? So they sent it to IR team. So this was taken about a couple of days later, when the patient was posted again for a left chemo port, left arm port insertion.
Yeah, I think that's an important point, that even though you've got one image, when you're actually going to do the procedure, it might be worth doing another one, because if you only had the original one, you would have probably placed the incision differently and then gone on a hunt for the chemo port. Thank you. Interesting cases. Yes.
Thank you.
For interesting presentation and discussing case of arterial function. So especially the elderly, what happens most of the time is carotid become calcified, so it is difficult to control once you take it out. It's not, pressure is not enough sometimes, and it is continue on the bleeding side. So it is better to take, as you have taken in the OT, and remove the catheter, good precautions. So same for the duration of the puncture, because this was puncture 1 day before and you have taken, I think, 2 days after the.
No, sir. It was puncture was done at around 4:30, 5 o'clock. And I've taken her at around midnight. So it's around 8 to 10 hours from the time of puncture.
Duration is also important, because if you puncture immediately and remove it catheter on the table and press it, then it might close. But if it is take a longer duration, so the arterial muscles becomes stretched, so it is difficult to control immediately. So those two things are there. One is the duration, and another is the carotid artery calcification. These two things might be the cause of bleeding, continuous bleeding in your case. So you have to be careful, especially if the patient is elderly. Any other comments?
I think Sanjay sir wanted to say something.
Yeah, yeah, no, very well managed case and very scary one also. So
Could have been better, sir, I feel. Could have been managed better.
Yeah, in the hindsight, do you think that removing the catheter by directly putting an incision over neck would have been better?
Could have been better, sir.
It's hypothetical, but suppose in future I have such patient, what would you recommend?
I think at least I have a direct vision on the carotid, so that I can keep my finger there, so that I can immediately put a finger and say that it is not going to bleed. Probably that is one of the ways we could have done it. I think that was probably the better way to do it. So that if you have an access right away there, if you are going to put your finger there, and if at all, if you need a clamp, you can right away put it and take care of the bleeding, rather than to end up having such a problem.
Yes. So I think we all should keep it in mind in case, although we should pray that we should not have
run
this,
through.
but
So, for 48 hours post this procedure, I kept on thinking what better I could have done, so that the patient should not have suffered so much. So another incision in the neck, probably putting that incision prior or getting her intubated prior. How I could have. I did have a big introspection for this case particularly.
Yeah, and second thing, I don't know, maybe using angioseal could have prevented the neck hematoma.
Sir, I have not used it. If you could further elaborate on that.
No, that angioseal device comes that interventional radiologists usually use it for femoral artery closure, right? After they do finishing their neuro intervention. So, so I have also not used it, but like I have heard and I have seen in few cases. So that could have been like that could be used. I think.
Another this one what I had a discussion is probably block using intervention radiology, block the proximal and distal part, take it out, make sure that there is nothing, and then probably you could have left it alone. So that is all these things did come up after I had a discussion and I shared these things with them. It was a big learning experience for me as well. I just thought I'll share this. So
Yes,
sharing will also increase the learnings of others as well. So that is how.
yes, it is big learning case for all of us, I think. Thank you for sharing it.
Thank you.
Before we conclude, if any of the panelists have any closing remarks, please feel free to share them now.
Can I make a remark? Yeah. Sarah and Abhishek sir wonderfully organized thing. Wonderful cases also from all the institutes. Really heartening to see so much of encouragement, involvement from all of us. So I am extremely thankful to the organizers as well. Thank you, everyone. Thank you, Gyan sir. Yeah, thank you, Sabha sir. Yeah, especially to Mishra sir, who has been the legendary visionary, Mishra sir, as always.
I also thank Sarah, Abhishek, Mishra sir, everybody who's part of the team. Very well organized. And I think this is a CME we have really listened and learned through each other's experiences and complications. I think this is very well organized. Otherwise, usually we don't listen online, but even online, we are so alert and attentive because every case is interesting and it's not the theoretical, it's just patient management related pearls we are learning. So it was very well organized. Thank you so much.
Thank you, ma'am. Thank you, Dilip.
Thank you so much for all the panelists and all the participants who presented the case. All cases were very interesting, very informative and learning for all of us. So it was a nice panel discussion and everyone has given a good input in this and we have learned a lot in this panel discussion. Thank you very much.
Thank you, everyone. And I hope the people who are connected through Zoom, they will send you a e-lunch also. So I thank you, everyone. And
it will be difficult to send e-lunch for Goom ma'am, I think.
I will need a e-breakfast because I woke up at 5 a.m. on a Saturday morning. So, but it was worth it. It was worth it. So I was sleepy when I logged on, but all my sleep is gone now, especially after Dilip's
Yes,
case.
this calculate case might have broken you up.
But I didn't get a chance to comment on Ganesh's presentation. It was excellent. I really wanted to ask him how he got into so much details with the techniques and the troubleshooting and also the tricks and tips that he shared. So it was a very thorough presentation and all the cases were very interesting. But thank you for having me. I think the last CME on TIVAD or chemo port from my memory that I attended was in SGPGI when I was in second year, I think. So it's been a good, I don't want to tell you how many years, but then you get my age. So, but it's been a few years. It's been a few years. So it was a good refresher course. So thank you, Abhishek, Sarah, Mishra sir, and everyone in the organizing team. And it's good to see Gyan sir and Sabha sir. Doesn't feel that remote. I feel I'm there. So thank you for having me. But well done and congratulations.
Thank you, ma'am.
Thank you, ma'am.
That brings us to the end of our case-based panel discussion. A big thank you to all our presenters for their insightful cases and to our esteemed chairpersons for guiding the discussion so effectively. To conclude the CME, I now invite Dr. Sarah Idris ma'am to deliver the vote of thanks.
Thank you, Ishita. Thank you, everybody who attended this CME. This was our first CME after Mishra sir inaugurated the digital studio for collaborative e-learning today. And this was our first activity after that. So thank you so much for all of you to participate and make this a good success. I want to thank all the speakers who have come here, Dr. Arjun, and who gave us their talks online. All the chairpersons and the panelists, Gyan sir and Sabha sir, who could spare their precious time and come all the way from PGI here, and all the other panelists who are with us online. Thank you so much, each and every one of you. We learned a lot today. I would also like to thank the Indian Association of Endocrine Surgeons, under whose platform we have done this CME. Thank you so much, Professor Anjali Mishra ma'am, Professor Pula Ramapas ma'am. And I would also like to thank all the presenters who have presented their complication cases. I would like to mention that we'll be sending out the e-certificates within the next 1 week. So you'll be getting them in your mail. Again, thanks to all our staff, our OPD staff, our OT staff for being so cooperative. It wouldn't have been possible without their support. Thank you once again.
Sure.
Thank you, ma'am. We hope today's sessions have provided valuable knowledge and practical takeaways. On behalf of the Department of Endocrine Surgery, thank you all for being part of this event. And everybody